Good afternoon, everyone. My name is Susan Lynn Osterly. I'd like to welcome you all to the 10th convening of the Low Value Care Task Force. Before we get started, I would like to go over some housekeeping items. First, we'd like to ask everyone to add their affiliation to their Zoom name. To do that, you click Participants at the bottom of your screen to open the participant list. You hover over your name and you click on the More drop-down button. Then just click Rename, and please include your first and last name followed by your affiliation. And we have an example right there with the lovely Ms. Jordan Clark. Then we wanted to cover how to raise your hand, although most of you probably know. We'd like this meeting to be as interactive as possible, so when you'd like to ask a question or make a comment, please raise your hand by clicking the Reactions button at the bottom of your screen, then select Raise Hand. Cliff will do his best to call on the members in the order that the hands were raised. Now, for those of you who joined with a browser, you're not going to have a Reactions button. You would click on More at the bottom of the screen, and then click on Reactions when that menu pops up, and then you'll be able to raise your hand. When it is your turn to speak, please remember to unmute yourself. We would like everybody to also have their camera on when they're speaking, if at all possible. And then after speaking, please lower your hand and mute yourself again. You can leave your camera on as long as you want. We would love to see you. And now it's my pleasure to hand things off to our esteemed monitor, Cliff Goodman, to start the meeting.
Thank you, Susan Lynn. Welcome, everyone, to, again, the 10th convening of the Low Value Care Task Force. There have been 10 convenings. They've all been productive. We have not only watched the low value care issue emerge, so many of the folks on this call have taken part in it and have even been leaders along the way. So it's a real pleasure to be with everyone today. We'll be working today from Eastern time-wise, from noon to 4 p.m. Eastern. So welcome all. Let's take a look at our agenda, which I think comes up next. Yes. Okay. Our agenda. We're going to be doing that slot of 12:05 to 1:30 Eastern. There are several things going on in there. The first thing, and this is kind of a heads up, after I go through the agenda, what we traditionally do is we ask for introductions for new attendees, folks that are who are either personally or organizationally new to the Low Value Care Task Force. And all we wanted to hear from folks, and please do raise your hand when that time comes, is your name, affiliation, just a few words like what brought you to this, what's going on in your organization, or what are you seeing either internally or externally that interests you in this issue of low value care. So that's a heads up. And again, once again, for those of you that are new, either as an individual or your organization, I hope we can hear from you briefly when that time comes back. Following those new member intros, we're going to go to some specific member activities, We're going to hear from Beth Bortz out of Virginia. We'll have about 15 minutes for Beth to give us an update over from the Virginia Center for Health Innovation. They've always been a leader here. We'll take about 10 or so minutes to present, 5 or so for Q&A. She'll be followed directly by Beth Bodan-Seiler from the Research Consortium for Healthcare Value. Beth will go as well for about 10 plus 5. So it'll be 2 very careful focused looks at some ongoing member activities. It'll be great to hear about those. Then, and from that space until 1:30 p.m. Eastern, we're going to ask for additional member updates. And heads up here, and I'll try to sort of organize this, and that is, we'd like to hear from across our member sectors. And so one way we might do it is to think of it this way. We've got members here from state governments, we've got payers and health plans, we've got employers, we've got academic researchers, clinicians, pharma bio device makers, patient advocacy organizations, and others. And so what I'm going to be asking you then is to think about any trends or factors that are redirecting or reinforming how we're managing or you're managing low value care. And again, this can be internally focused or externally focused. We're not asking for any trade secrets or anything like that, but we like to know what you're doing or what you're seeing along those lines. Again, what's any new stuff, trends or factors? Now, another thought I'm going to pump in there to keep in mind is a related question might be this, and I hope you're thinking ahead on this. How has the pandemic revealed any new insights on managing healthcare spending or disparities? So those are a couple of kind of trigger questions or kind of prompting questions, as it were, for you to keep in mind. And the reason it might be interesting to hear about healthcare spending or disparities is that immediately following that discussion, we're going to hear from David Cutler, who's going to talk about reducing unnecessary healthcare spending and the tie-in there with low-value care. Immediately followed by Meredith Rosenthal, who's going to address low-value care and health disparities. So it might be a great kind of setup to get us thinking about healthcare spending and disparities. After that, and that'll take us to mid-afternoon. I should say, excuse me, before that, before I'm setting up Cutler and Meredith Rosenthal, but before we get to them, Mike Cherner is going to talk about the low-value care updates vis-a-vis evidence, policy, and practice. So it'll give you some more time to think about that. So it'll go the intros, Cherner will take a break, return to Cutler on healthcare spending, immediately followed by Rosenthal and low-value care and health disparities. And then we'll wrap up with some next steps and adjournment. So there's a lot that we can pack in here, but I hope I've kind of given you some, like a heads up on some of the kinds some things we'd like to hear from you on updates from new and continuing members. So that's the lineup. Okay, I think let's see what the next slide is, Susan Lynn. Yeah, okay, now let's do this. Folks know where the raise your hand function is. And I know we've got some new folks here. Either their organization is entirely new to the Low Value Care Task Force, or the organization is not new, but they are personally. Can we hear some of those new folks' intros, please? Can I see a hand up to get us started? Okay, Tracy Kilmos, tell us who you are, with whom you are, and what brought you here, Tracy. And I think you're on mute.
I'm trying to come off mute. So there you go.
Tracy.
Hi, how are you?
Great.
And hello to my colleague in the Defense Health Agency, Mr. Joe Muro. So thank you. I'm here because Joe suggested I come. My name is Tracy Perez Comus, and I am the director of the Center for Health Services Research at the Uniformed Services University. So I am that in the Venn diagram overlap of federal sector, Department of Defense, and academic center. So there's all sorts of good things and bad things about that. I lead a program called the Comparative Effectiveness and Provider-Induced Demand Collaboration that has a whole segment that focuses on low value care. So we've published multiple papers, and some of our work's been translated into programs and actions on this. And I don't get out much. Again, as a DoD employee, I don't get out much, but we do low value care work. We do a lot of comparisons between the military direct care system and the purchase care system. Oh, and I'm a professor. I think I'm supposed to say that I'm like an actual professor. So I'm going to be done now.
Well, we hope you're not done for the whole day. We hope to hear from you a little bit more later in the afternoon, Tracy. Very cool to understand what you're doing. You bring us several perspectives, including a professorial one. And the comparative issue about the military versus other health systems can be revealing in itself. Welcome, welcome.
Thank you.
Thank you. Next up is Dot Verbrugge. Dot, who are you, with whom, and why are you here, Dot?
Yeah, can you hear me?
Very well.
Hi, Dot Verbrugge, family practice and medical director, vice president of clinical quality at CVS Aetna. I see my manager, Q Ree, is also on the call today, and just really interested in moving forward ideas about how payers can help limit and drive incentives to limit low value care. Thanks.
Excellent. And Dot, you represent a pretty large organization, what with, I guess, Aetna and CVS. So you have a very broad perspective, I would think, correct?
We do represent a Fortune 4 company now. So yeah, we're pretty big.
You're a big player. Thanks, Doug. Great to have you here. Let's move over to Adrian Casepear. Adrian? You're on mute, I think.
Can you hear me now?
Yes.
The dreaded double mute.
Right.
I'm a health services researcher by background. I'm a director now of clinical analytics at Humana, and we're a small, relatively new team exclusively focusing or predominantly focusing on low value care. Yeah, looking forward to the conversation.
Great. Just, Adrian, just tell us a little bit more about, are there any particular aspects of low value care or anything else that kind of prompted either Humana's interests or your interest in the field? What kind of prompted that?
Well, it's certainly something that as an organization, you know, we have lots of pockets that have looked at low value care. This is the first effort to bring it together in a sort of centralized way. What brought me to this specific call today was, quite frankly, a call with Mike Chernew and Mark Fendrick. Yeah, I think we've looked at low value care in specific instances and on the research side, and this is one of the first efforts to really go at it from a clinical analytics work stream approach.
Excellent. Great to have you here. So glad you're here. Thank you very much. Over to Matt Bartels. Matt?
Hey, thanks. Cliff, can you hear me?
Very well.
Great. Matt Bartels, I'm currently Chief Medical Officer at Blue Cross South Carolina and previously was a CMO up at Excelis Health Plan in New York. So I have about 16 years on the payer side. A pediatrician by training, have practiced in multiple settings. I've launched a program up in New York centered on choosing wisely in low value care, and a couple of my colleagues on the call today have helped launch a similar but different program in South Carolina, Dr. Kapp and Michelle Davis, who I think you guys have heard from before. So I've been trying to get to this meeting, Cliff, for probably 2 or 3 years now. So this is the first time I've been able to coordinate it with my calendar. So I'm really happy to be here and listen.
And we're glad to have you here, Matt. Thanks for sticking with us and making the date today. That's great. Let's move over to Tilak Verma. Dr. Verma.
Yeah, hi, good afternoon. Can you hear me?
Yes, we can.
Okay, so I'm from Point 32 Health, which is the new post-merger name for the Tufts Health Plan and Harvard Health Plan located mostly in the New England area. I'm covering for Dr. Michael Sherman, who is our Chief Medical Officer, who usually attends. My background is in pulmonary critical care and sleep medicine, and I'm the Medical Director for Medical Policy for both those legacy companies. Our usual mode of making policy consists in part of having medical specialty policy advisory committee meetings. And on the legacy Tufts side, one of the things that we did at each meeting was give examples of low value care, which I generally obtained from the American Board of Internal Medicine. So looking forward to this discussion. I'm a first-time attendee, so hoping to learn something new.
Thank you, Tilak, very much. And of course, there's been interesting communication over the years between this effort and the ABIM, of course, given the work they've done in the area. And heard you mention sleep medicine. Certainly, there's so many kind of sort of diagnostic and therapeutic interventions in sleep and so forth. A lot of them are probably highly effective, and maybe a few aren't so effective. And so it's good to have your clinical insight as well. Thank you very much. Let's move over to Denise Giambalvo. Denise, how are you?
Well, thanks. And thank you for pronouncing my name properly. I'm Denise Giambalvo here with the Midwest Business Group on Health. Typically, Cheryl Larson serves on this task force, and she is speaking in New York. So I'm here in her place today. I'm happy to be participating.
Thanks, Denise. Are you headquartered in Kansas City? Was it? Where are you headquartered?
Chicago.
Oh, so you are in Chicago. Just put you on the spot for a second. Denise, what's on your mind these days about low value care? Any kind of issues arising internally or externally?
Oh my goodness. Yeah. So I'd say, with everything that we look at, we're looking at where low value care is involved. So many different initiatives going on right now. refocusing on hemophilia this year and where low value care exists there. We're doing work around obesity. And actually, I just left a multi-stakeholder meeting on mental and behavioral health. So I'd say those are 3 high topics for us.
Wow, a lot going on in all 3 of those areas. I happen to know with hemophilia, there's a few new therapies that have been coming along,
Yes.
extended therapies, and now I think they're getting into gene therapy
Gene
as well.
therapies, yes.
Yeah, hot area.
Yeah, very hot area. How do you?
And a rare disorder. And there's a lot of just
Yes.
attention and kind of moving over to multiple therapies for rare disorders, including gene therapy and others. So an
Right.
area
And
that
a huge expense for an employer, right? So when you do have a member or members with hemophilia, big expense, and they want to make sure that the money's going in the right place, right? That the patient's getting the best outcomes possible.
absolutely. So between hemophilia, obesity, and mental behavioral health, you've got your hands full. Thanks very much, Denise.
You're welcome.
All right, next up is Q Reed from CVS Aetna. Dr. Reed.
Hi, yes, Q-Ray, and a med-peds physician by training, and I serve as a senior vice president and Aetna chief medical officer at CVS Health, and now excited to learn more, and was big fan of Michael and a number of other names I see also on the list. So I'm happy to participate, and I know my colleagues Wendy and Dot, who you just met, are also on. So we're all very excited to participate. Thank you.
Thank you very much, Q. And I know that you've got a background, several parts of your career, including in the federal government. You've held some positions there as well as the private sector. So great to have you here, sir. Thank you. Let's move over to Carol Mendoza. Carol.
Hi there. Good morning. Good afternoon. Carol Mendoza, longtime member of the task force, but with a new employer. I now lead benefits at Voya Financial.
And Carol, Voya is I had to look it up. It's a new outfit from my perspective. Can you tell folks a little bit about what Voya is and what it was before?
Yep. So we are the legacy U.S. Arm of ING, a Netherlands company. We split and went public in 2014. We do retirement administration, life insurance, stop loss insurance. So it's kind of interesting to run benefits for a benefits administration company.
Yes, and I know that Voya has done a really good job at kind of doing that sort of scrutinizing set of activities and so forth. And this is a really important area, and I know that you've got quite a scope there. Thanks very much, Carol.
Well,
great.
And I'm really excited to hear about health disparities later. I love the intersection between low value care and health disparities.
You will have a fine dose of that, I promise you, from Meredith Rosenthal. She knows her stuff. Thank you. Okay, I think I don't see any further hands raised. By the way, if you've spoken and you no longer want your hand raised, you can kind of take it down. But I think those are all the hand raised I've seen. Wonderful. Gosh, thinking of all the things, I just made some notes about the sort of the scope of interest that you bring from the public sector, the private sector, consulting, financial benefits, employer, pharma, good gosh, disease areas. This is wonderful. So we have all very nice sort of enrichment of views here from our new members here. Thank you all so much. Okay, in a moment, we're going to introduce Beth Bortz, followed by Beth Bodan-Saller. But once again, the heads up reminder, after we hear from Beth and the two Beths, we are going to go back for member updates across the various sectors. And remember those 2 questions I posed. So I hope folks will be ready to kind of bring forward their latest and greatest, whether it's an internally focused or externally observant phenomenon. Let us now move to our member activity updates. And I think we're going to have Beth Bortz up next. Beth, of course, is from the Virginia Center for Health Innovation. Beth has presented before to this group, and I think she's going to be bringing up her slides with a screen share.
I am, and I'm just looking to Susan Lynn, and am I good to, are your slides going to come down? Am I okay to pull mine up?
You are, just go ahead and grab them.
All right.
Beth, it's great to have you back. And what's been so great since, I know you've been involved in this since the beginning, is to just kind of watch how your folks in Virginia have sort of progressed along the way and really been leaders at the state level with regard to smart, focused, evidence-based examination of low value care. So welcome back, Beth, over to you.
Well, thank you so much. Can everybody see my slides okay? Are we good?
Yes.
All right,
view.
excellent. Well, thank you for having me. I think this is the 10th meeting, and I think this is probably my 10th meeting. So I'm excited to be back with this group. You've heard me talk before about our work in Virginia, our Smarter Care initiative. I will share with you just very briefly that is continuing. We are 2.5 years in on that initiative. I will say COVID has been a challenge to that work. A lot of our health system teams have been diverted to other issues, lots of things going on. We actually are hopeful. We have requested an extension, an additional year from Arnold Ventures. I don't have an answer on that yet for you. We should know very soon about that. But what I wanted to talk to you today about is a new initiative that we have underway, in which many of you are going to hear from me, I believe, in the next few weeks with a request. And so I wanted to tee it up here today. So in our work, we actually, at our organization, the Virginia Center for Health Innovation, we've got the two big initiatives, Smarter Care and a Governor's Task Force on Primary Care. We've been working very closely with our primary care community. One of the things that we frequently hear from the primary care community is a question of, does low value care really pertain to primary care? Which of the measures relate to primary care? What should we be focusing on? How much do we have control over? I heard all of that. It got me to start thinking, also started thinking about just how much this group has grown and the topic of low value care has grown and how much work I'm seeing about measurement in low value care. And the concern that I started to have was that we might get to the point where I feel like we are on clinical quality measures, where there's so many measures being used by so many different entities that it almost becomes meaningless. And I know Mark and Mike have worked really hard to get this group focused on a top 5. We've been part of that effort, but I felt like there was going to be a real need to focus the community on a core set of measures for primary care. And so I'm delighted to share with you that we have gotten funding from AHRQ for an initiative called Advancing and Improving Measurement and Value in Primary Care. So what is this? We partnering with the Center for Professionalism and Value in Healthcare, which is a spinoff of the American Board of Family Medicine. And the University of Michigan and the VBID Center, we all came together and requested a 1-year ARC conference grant. And what we asked for was to launch the 5th in a series of Starfield Summits. Some of you may be familiar with the Starfield Summits, named after Barbara Starfield. In the primary care community, these are kind of the big convenings around important topics. And so we went to the American Board of Family Medicine and asked, could we use that vehicle you've already created, the Starfield Summits, to have a conversation around primary care measurement, measures that matter for primary care, and specifically around the measurement and reduction of low value care. And so when they said yes, that is what we pitched to ARC, was to have this 5th Starfield Summit, and that is what has been funded. So what are we hoping to do? We are hoping to convene groups virtually to have this conversation about measures that matter. If you are familiar with the primary care community, they have already got a Measures That Matter initiative underway, where they are really trying to discern a handful of measures that are critical to primary care and to try to use those to drive improvement and payment reform. We want to have a conversation about low value care be part of that core set of measures that matter for primary care. And then we want to have consensus across user groups as to what the specific measures should be that we would use in payment reform. And then the idea being that we would roll out a dissemination strategy so that we try to get as many folks on board with using this agreed upon set of consensus measures. So how are we going to do this? The objectives that we've laid out, we have already identified a planning committee, which I'll share with you in a second. We're going to be working on putting together an advisory group of 50 leaders across primary care and measurement and development, low value care, payment and measurement policy. We are working right now on a detailed literature search to try to get us anything we can on what low value care measures are already in use that apply to primary care. We're going to do a series of structured interviews with everyone that is selected as one of the advisors to help bring those perspectives to the table, and prepare a white paper that summarizes the current state of primary care measures that matter and low value care measurements specifically. Then a set of criteria for how do we choose which candidate indicators and measures should we select. We will then review all the data sources and measurement tools to try to evaluate the feasibility if we really want to tie this to payment reform, select our initial set, and then have the dissemination plan. So you can see here, this is the group that came together initially to be the planning committee. So in addition to myself, you will see Mark and Mike are on here. Some of you may know Alex Christ, who's the U.S. Preventative Services Task Force Chair, and then some folks from family medicine involved here, the Center for Professionalism Value, health plans, and health systems. Then there's this 50-member advisory committee. This is the real heart of what's next, is us choosing who will be part of these virtual conversations. You'll see we've kind of spelled out the different entities that we think should comprise the 50. And if you're on Mark or Mike's list for this group, consider yourself fair game for a call from me soon, asking you if you would be interested in serving in that capacity. And then finally, I'll just share our timeline. We're putting everything together now. It will be 4 shorter virtual meetings. We felt that would be more effective, and that we will have some ranking and review surveys that will be done for us between meetings to help us get to that consensus set of measures. And so that is what I've got for you this morning or this afternoon, and I'm open for any questions that you all have.
Thank you very much, Beth. And folks can do the raise your hand function if you have a question. Tracy, did I see you send a chat over to Beth? What was it that you wanted her to share, Tracy?
I didn't know. I didn't want her to share. I wanted to ask you, Beth. So we took a set of measures probably developed by people on this call. I don't know if Chua et al. Are on the call, but it's a pediatric set of measures, and we compared our kids in our direct care system to kids that we send out to private sector care, so pediatrics. And across the measures, we found that our kids were getting way too many inappropriate antibiotics. And if you're doing a systematic review, I want my work included in that. So we did.
Please send it my way.
Work. Yes, ma'am, will do.
Absolutely.
Thanks.
I would encourage any of you that have measures that you want to be, part of that initial bucket that we look at, absolutely send them my way.
Great,
thank you.
Thanks for making that connection. Denise Gimbavo, you're up.
Thank you. So is one of your intentions to get primary care to move from fee for service? So with creating these measurements and proposing new policy.
Absolutely. Selfishly here in Virginia, we are actually, as I mentioned, I kind of have 2 initiatives and I'm trying to actually align them. We have our smarter care, low value care work. We also have a governor's task force on low value care. On primary care. That governor's task force is actually charged with moving primary care to value-based contracting, we are trying to work to choose the measures that will be there. Our Medicaid agency is actually looking at completely changing how they pay for primary care in Virginia, and they're looking at the measures development. So this is all kind of bringing all pieces together. We want to make sure that we have good low value care measures in the set.
So I have a couple more questions. You're talking about governors coming together. So some states mandate vaccines, others do not. So when you're looking at policy, will you be considering that across the board and how to raise states up?
Absolutely. And in fact, you know, we are very flexible here in Virginia, because in about a month, less than a month, we have an election and no one knows which way it's going to go for our governor's seat. So we are, you know, we will be looking at, you know, both kind of ends of the spectrum on policies.
And then one final question, are you also considering collaborative care? So behavioral health as a measure of treating, identifying, treating at the primary care level?
We are. I will tell you, behavioral health is always a intense discussion in our Virginia meetings. Not because there's question about including it. The bigger challenge for us is always the data piece. It is really hard. The behavioral health claims are not, for the most part, in our APCD. So it is challenging, but there is an intent to include behavioral health.
Thank you.
Great. So Beth, there's a question from Ali Lapidus from Pharma in the chat asking, are you planning to work with primary care providers in medically underserved areas? And I wonder if the measures will vary based on the population served. Good question.
Absolutely. And if you were to look at the Commonwealth of Virginia, we have many medically underserved areas. So that is always a piece of what we take into consideration. What we are thinking, what we have talked about with our plan representatives here in Virginia is that rather than this being a concrete set of these are absolutely the measures you have to use, we just want to create a smaller menu, if you will. So there will still be some flexibility in choosing and contracting which measures are selected based on specifics of the practice.
Good point, well taken. So being able to calibrate by the kind of population whom you're serving is important there along the lines of measurement. Nancy Junto from Washington points out in the chat that there's a lot of stuff going on in Washington there with regard to aligning measurement in primary care with payer models. And so obviously that was one of the questions that came up just a few minutes ago. And so it'd be good to kind of watch each other here between Virginia and Washington across the country about how you're making that alignment work.
Well, if Nancy thinks there's a chance that her name's not on that list, she's not paying attention. So there will be plenty of opportunity for Nancy to share with us, I guarantee.
Okay, well, she hasn't hidden from you yet, and I still see her up on the screen. That's cool. So Beth, just a follow-up question before we move on, and that is, as you know, and most folks on the call know, when this group went through a process to identify a top 5, there was a lot of kind of, what's the process for setting, what are the criteria, what are the priorities? To what extent is your group sort of working on trying to come up with the method of setting the priorities? Can you say a bit about that?
Absolutely. So when I said there were 4 meetings, the reason there's 4 meetings is that the very first meeting is to really start to agree on what are the parameters by which we are going to be choosing measures and getting agreement on that before we even get into the actual discussion of the indicators and measures.
Okay. Always a tricky set of exercises to come up with criteria and voting and all that kind of stuff. Any final questions for Beth before we move on? We have a bunch of questions. There's some other stuff in the chat. Thank you. Beth, great presentation. We'll be tracking it. Thank you. Gwen Darian popped into the chat something about the National Academy of Science, the NASM study on implementing high quality primary care. Nice resource for you there.
Yes, and in fact, the lead authors are part of our planning group, so they are very much involved.
Fantastic.
Perfect.
I did a presentation and then was one of the reviewers of the publication, so I know this very big study pretty well.
Yes.
Great.
That's great.
Great.
Thank you, Gwen. Thanks, Gwen, for popping that in there. Okay. Any further comments? Did Nancy have to say anything else? I think we got Nancy's input. Yeah, okay. Let's move on to Beth number 2, Beth Bodan-Seiler. Beth was with the Research Consortium for Healthcare Value. Beth, I know you've been working on this kind of stuff for a while, been tracking our group very much. What do you have to share with us today, Beth?
Yeah, thanks, Cliff. It's always tough to follow Beth Bortz, but I love everything she has to say. So let me see if I can share my screen with you and get my slides up there. How does that look?
We can see them in side-by-side mode, I think, but that's fine. We have your next slide to the right, but it's all visible.
It's all visible. Great. So I'm really excited to share with you what we've been working on at the Research Consortium this year. Earlier this year, we published our 10th concept paper through the consortium. My colleague Ani Turner and I talk about advancing health equity by increasing the access to high value care. And this is something that we talk about, not only advancing access to high value care, but talk about the current disparities that are occurring and the access to healthcare and the access to quality healthcare. And we talk about the inequitable burden of low value care that happens in vulnerable populations. So the lost time and challenges with transportation and the financial burdens and the trade-offs that occur because we can't pay for everything, and really the erosion of trust between the patients that are unduly burdened by these issues and their healthcare providers. While the evidence may be mixed on whether low value care is more prevalent in disadvantaged populations, the real takeaway is that the fact is that this is complex and it's multidimensional, and we need to have a focused research agenda on what to do about health equity and disparity issues. And we happily provide our opinion on what that research agenda should be. Additionally, this year, we have worked on a small exploratory project where we're looking at how safety net hospitals are defined. What components of that safety net hospital definition do we need? What's the what are the components that are problematic? How do we know when these hospitals are providing a level of value to their communities that they reside in that's appropriate? The project had 2 phases. We did a literature review, and we conducted 5 qualitative interviews with health policy experts to just better understand the challenges in the current definition of safety net, as well as barriers to changing the definition. We also asked what could be done on a smaller scale to really push the lever of value forward. But what we're really excited about is once again building off of the success of our 2020 grant center funded by Pharma last year. And again this year, we were able to select 7 awardees to develop research briefs, which will be published in a Health Affairs blog series and discussed at a webinar that will be hosted on Wednesday, November 3rd. Let me see if I can advance my slides here. So this year, the series is entitled Advancing Healthcare Value Through Data Measurement and Evaluation of Services and Procedures. Health technology assessment was the focus of this year's awards, and the discussion of how we measure and evaluate the value of the returning services and procedures that we're seeing in the healthcare system since the start of COVID-19. All parts of the system should really be accountable for making healthcare affordable and of high value. Discussing the barriers and the challenges that exist in this space can inform a research agenda that will provide more robust evidence on effectiveness and value of these healthcare services. As I said, Health Affairs will publish a blog series on these papers throughout the rest of 2021, and we would love to have you join us if you can on Wednesday, November 3rd from 1 p.m. to 3 p.m. Eastern Time, where the authors will discuss their work. And we are once again very happy to have Mark Fendrick moderate this discussion for us. I'll put a link in the chat to the webinar registration. But if you have any questions, please feel free to email me And I'll also put a link to the paper, our health equity paper in the chat box as well. Thank you so much for giving me just a little bit of time to update you on what we are doing here at the Research Consortium.
Thank you, Beth. Beth, could you put your slides back up for a second, by the way? Just want to,
Oh,
if you don't mind, I want to go back, if that's kind of technically doable here. And of course, if folks have questions, they can pose them to Beth. We can do the slide share. I'm not sure if you can find that again. There we go. Previous slide. And excuse me, the one before. Slide 2, please. Yeah, okay. So here's a question for you, Beth. And as I said, if folks want to pose questions, please do raise your hand. I think we all recognize the issue about health equity and actually health inequity in our country. When you're trying to increase access to high value care, is there an issue of having a lot of low value care in the way of all that? And is there sort of it's kind of the medicine cabinet issue, which is if you want to add something to your medicine cabinet, sometimes you got to take a few things out. And is that a kind of an issue that's arisen in this discussion with you? Because as we've heard and we're going to hear, people who are subject to healthcare disparities sometimes get an abundance of low value care. Any thoughts on that, Beth?
Yeah, I think that is resonates a lot with what Mark and Mike constantly talk about, which is making the headroom, right? We need to take out the low value care services so that we can make that headroom for the high value services that are needed. I think that what we really what struck us in our literature review when doing this concept paper was how much trust and respect is going to play into the disparities conversation, right? It's not just a message of removing the low value care that's occurring so we can create the headroom for the high value care. It's also about reestablishing a sense of trust in the provider and healthcare professional community with these people that are unduly burdened by some of these low value care services that are occurring because they're compounded, right? If you didn't need that service to begin with, but it's compounding the fact that you needed transportation and childcare and you lost work and you had to take time off and you know, all of these things. Now we're eroding the trust, and that needs to be addressed as well.
Point well taken. Thank you. Q-Ree is asking something about, and this I was echoing the statement, is it really accurate that health disparities populations are more likely to experience low value care? I'm pretty sure that Meredith Rosenthal is going to be able to address that question. I don't know, Beth, if you've got anything you want to add to that on that particular issue?
Yeah, I'll let Meredith really speak on it. Our findings were that it's mixed. It's quite often mixed. It depends on the population. It depends on the payer, Medicare versus commercial. It depends on a lot of how the research was structured. So right now, I think our biggest takeaway was that this isn't simply a one-dimensional issue, that there are lots of things that are contributing to whether or not we're seeing more low value care occurring in vulnerable populations. There needs to be solutions that come at it from many different directions.
Got it. I'm going to we'll hit on all these questions, but since we're on the matter of disparities, Q-Ree also asks, who do you define as a health disparity population? Beth, did you want to take a go at that? How are we defining health disparity population, subject to health disparities?
Yeah, so like in our concept paper, in our work, we looked at low socioeconomic and minority populations. Obviously, there is a lot more that could go into that definition, but that is what we looked at.
Okay, and keep in mind, I think, and we've all been talking about this, when you think about disparities, it's disparities in access as well as disparities in outcomes. So sometimes they're not always directly related, but it's sometimes, even if the access is pretty good for some other reasons, the outcomes are disparate as well. we need to think about closing that gap. Muna Banji is asking about medical and social care needs. Muna says, would it be fair to assume that in this work, we will consider how medical and social care needs are linked so as to get after the system inefficiencies? Beth, you must have looked at that too, huh?
Yeah. The social determinants of health is really what we mean by that complex issues that are going on. And I think that when we're thinking about health inequity and the disparity that we see, to not address the social aspect of that is not going to get us very far. So that's a great comment.
Yep. Curie also popped in there, rurality. Yes.
Yeah.
Urban, suburban, exurban, and rural populations, there is sort of a gradient there of access as well. Beth, you could look at that too?
Yeah, that's great. That's a great comment on rurality.
Yeah. Right. Beth Bortz is pointing out, and I think this echoes her earlier statement, Virginia is such a diverse state, geographically, socially. I know kind of those of us that live near Northern Virginia around the DC area, that's one economy. And then there's an economy kind of in the Southeast along Norfolk and so forth, Hampton Roads. Then as you move further west and south, it becomes quite rural and moving to Appalachia and so forth. So I know that Beth has seen a lot of that diversity and diversity in disparities of type in the state of Virginia. So thank you very much. And she also pointed out, this is great chat. I hope we're capturing this. Beth said, we're actually seeing more low value care in high income communities and less high value care in low income communities using the area deprivation index methodology. Yes, happen to know a bit about that. The area deprivation index, the ADI, Beth, correct me if I'm wrong, I think it's got like 17 variables in it or something. Like, do you have a phone? How many rooms per house? All kinds of socioeconomic indicators. It's been very useful. Originally developed, I think, by the University of Wisconsin. Mm-hmm. Good gosh. And Tracy from USIS points out there's a common use tool based on this. Yes, Mark Fedrick, I was just going to call on you. Just want to I think
it'd only be fair to the country's expert in this area, Meredith Rosenthal, that I was worried. Beth and I were going back and forth about whether we should light the equity fire during the member updates, and my decision was incorrect. So okay. I'm going to ask, since I think we have a fair number of members who want to chime in before Chernu takes over. And that one of the reasons you probably know, Cliff, I put the equity part at the end is because everyone wants to talk about equity. So in fairness to Meredith, I'm just going to ask you nicely to potentially defer this chat till we have our expert on the line so she could chime into those things and not miss a majority of this conversation. Thank you.
We've got it. Well, actually, Mark, what we wanted to do is get this input and help set Meredith up, because we know it's a hot topic and she'll be able to address some of these very questions. So I think we did want to provide folks a chance to speak up about it. And by the way, Tracy from USIS points out there's a community use tool based on zip codes that are familiar with that as well. So, okay, any further points for Beth Bodan-Saller on this issue here? Beth, you certainly kind of prompted a whole slew of questions, I must say. Thank you.
Thanks for your time.
Excellent. Okay, actually we were right on time now. What we'd like to do next is this, on any of the above. We have heard from our new members. We have heard from our two Beths. Already have a lot of comments in the chat and questions on these various issues. We want to return now to, and this is open to all members here, to find out any further member updates. And we'll be looking for raised hands, and we can take this all the way to 1:30 Eastern if you like. Let's see how it goes. And I want to point it out a couple ways. One, keep in mind that we have representation from various sectors. Like I said, state government, payers and health plans, employers, academic researchers, clinicians, pharma bio device makers, patient advocacy, and others. What we'd like to hear from you, and maybe I can maybe start sector by sector, is to answer one of two questions with regard to updates. And I'm not confining it to this. If you've got a different kind of update, glad to hear it. And I know that John Keats already has his hand up, which is great. Let's start with the payers and health plans. Tell us, are there any trends or factors that are redirecting or reinforming how we're managing low value care, and or anything about the pandemic that's revealing something else about managing these, including via healthcare spending or even disparities? John Keats, let's take a lead off among the payers. What do you have for us, John?
Great, thank you very much. So as always, very happy to be here. You're off to a great start, Cliff. Always a fantastic job as our moderator. So what's happening at Cigna, where I'm the medical director for affordability and especially partnerships. Where I'm the medical director, working very hard to value care into wheel organization. I think we're very close to being able to get our data analyzed across really our entire book of business by the start of 2022. That we will be able to take a look at where the low value strategies to counteract that, and I formed an internal group of like-minded individuals that were low value care is, develop strategies to counteract that of like-minded within the company.
Cliff and John.
Hey,
it really has come to light. Cigna is very active.
John, we're breaking up a little bit,
Yeah.
I think, John.
Yes.
We're getting about 20% of it. I don't know if you've got a connection issue, or perhaps you could put that in the chat.
Okay, I'm so sorry that you're not.
John, maybe
you're not
if you turn
hearing
your
me
camera, if you turn your camera off, we might be able to hear you better.
Yeah.
No kidding. All right. Well, I'll do that. How about that? Does that make a difference?
So far, yes. So far, yes. Please just rewind a little bit, John. We caught some of it, but not enough, John.
Okay, so to rewind, trying to get the Milliman Healthways calculator incorporated starting in 2022 to be able to define where low value care is. I formed a group within the company called WOW, which is War on Waste. We're trying to be more proactive in this area. And we are looking, Cigna has a lot of activity going on in general in health disparities and health equity. And we're trying to tie those two functions together, which is why I was very fascinated, not only to the last conversation, but of course, looking forward to the speaker later this afternoon. So we continue to move forward and hope that our colleagues in other health plans will be doing the same.
That's great, John. Thanks. We like the idea of war on waste. So, John, just to encapsulate it then, what is the current sort of motivating factor that's keeping you focused on the issue? Any other trends or observations? Because you have remained so clearly focused on it and then you're kind of turning over some new activities. What makes you kind of stuck on this?
Well, it is just an enterprise focus on affordability. And I've made the point, and I think it's been heard at the highest levels, that if we really intend to have very lofty goals for affordability, which we do in terms of reduction of total medical cost, that there's no way we're going to get there without addressing low value care and eliminating low value care from the system. Creating, as everyone who's ever attended any of these meetings know, the ultimate goal, of course, being to create that headroom for high value care. You asked about the pandemic. What we're really most concerned about, and there unfortunately are some statistics coming out now, is that many cases, particularly in cancer prevention and early diagnosis, people have foregone some very high value care in terms of mammographies, colonoscopies, et cetera. And I think we're going to reap the whirlwind a little bit on this as we're starting now to see the tip of what I'm afraid will be a very large iceberg of more advanced cancers from people that have foregone screening. So we're very concerned about that, trying to get the message out to people that they must maintain the utilization of these high value cares at the same time that we're also focusing on low value care.
Great point, Sean. Thank you very much. And yes, later diagnosis, you see in stage 1, move to stage 2, stage 3s instead of stage 2s and so forth. So later staging is coming up in the cancer field. Thank you very much. Out of the DOD, Joe Miro, over to you, sir.
Thanks, everyone. As I promised Mark, I'd say a few words. I partner with Tracy Perez-Kumus in the development of the next generation of, of TRICARE contracts, which I'm the program manager for. So we're a big payer. 2019, we spent about $8.4 billion on healthcare. I like the war on waste. That's good for us too. We also have an enterprise focus on affordability. As Dr. Fendrick says, when you get rid of low value care, you can buy more of the good stuff. For us, the good stuff is warfighting capability for our soldiers and all the folks who are deployed and at home and abroad. So we do have a laser focus on this. We've incorporated into our next generation of TRICARE contracts, which are actually out for bid right now. And you can look at our RFP. We're really looking to leverage our support contractors, our managed care support contractors, to help us target and reduce low value care. Over.
That's very helpful, Joe. By the way, you talked about warfighting capability and sort of capacity. Could you comment briefly on the readiness, let's say it this way, the socioeconomic status and health of the force? We know for certain reasons that the people that are in the military don't necessarily represent the broader population from a variety of standpoints. And are there disparities with which you need to deal? There is a different population there. Any comments about how you're managing that and what implications it might have for readiness?
I have to turn that over to the scientists. Tracy, you got a comment on that for us? I know you're looking at it. She must be. So it is a focus of our head of personnel and readiness, the department, the TRICARE health plan falls under the Defense Health Agency, which falls under personnel and readiness. So all of those issues are sort of integrated at that level. And, it's part of an overall approach to the health and welfare of our armed forces to integrate those factors together.
Point well taken. I know just stuff we've seen in the news and so forth, there is housing insecurity and food insecurity in some of the folks coming in, and that's always a challenge to be dealing with, of course. So it is relevant to disparities. Thank you. And great input, Joe. Thanks. Others from the payer community. And I see Carol Huffman, and she'll be followed by Lloyd. Carol?
All right, I'm just trying to come off mute. Hey guys, it's really nice to see you. I missed you all. So it's great to see your faces. One of the things that I remember from a prior task force meeting, Cliff, was remember when we were talking about what are the things that are happening during COVID? What are the innovations that are happening during the COVID experience that we don't want to lose sight of? And what are the things that we didn't do anymore that we don't want to go back to? Do you remember that conversation?
Yes, and COVID's such a tough thing, but it might sort of reveal or help us revisit some things we need to deal with anyway. You're right, Carol.
That's right. So one of the things that struck me is with the hospital shortages, with the SNF you know, staffing shortages for, you know, things like across the whole healthcare system, whether it's SNFs or hospitals or PCP groups. One of the things that we have started to do with one of our hospital systems is look at the post-discharge process to make it more efficient so that we can not have the readmissions, which in the post-COVID environment is actually a win-win-win for everybody because of all those things. And so something that worked really well during COVID at one of our systems, hospital systems, was a special post-discharge management program for COVID patients. And now we're looking at that saying, oh gosh, that worked really well. How could we morph that into, you know, serving members maybe who are COPD? And so all of a sudden, this idea of a higher value service in substitution for a lower value, which might have been, you know, someone who ended up being, you know, readmitted, is getting embraced across the whole system. It's getting embraced by the hospital, the PCP, the specialists. And so we're really seeing something new here that has allowed us to use the words low value and high value in settings across our whole network. So Mark, you know, we were talking about this a couple weeks ago, and it's really coming to fruition, and we're getting excitement in a way that we've never seen before. So Dr. Del Cole and I just want to mention that, you know, it's really important to kind of go back and look at what was happening, the innovations happening during COVID, and now using that to inform us for, you know, what else could we do better in the post-COVID environment.
So Carol, you just described nicely what's basically a case example here.
Mm-hmm.
But what principle or observation or tenet does the case example illustrate about this unusual black swan event, as it were? Something happened unusual. What's the lesson from it?
The lesson from it is that all of a sudden there's these forces that are making substituting low value care for high value care important across the whole system, and that didn't exist before. And so it's an opportunity for folks to kind of step back and say, what's in it for all of the stakeholders? And we talked about this before, where, you know, understanding the stakeholder perspectives is so important in being able to promote, you know, high value versus low value care. And so to me, I'm just seeing this intersection in the forces right now that is giving us opportunities that we didn't have before. So it's really a nice, I think it's good for folks to kind of step back and look and see what's going on now that makes the stakeholders, you know, more willing to listen to this notion of high value care versus low value care.
And it has happened. And directly pursuant to your point, Carol, is a chat from Jeff out of Anthem, where he says, you know, COVID has also moved more procedures to the ambulatory setting, thereby creating opportunity for value and cost avoidance. It's also accelerated the movement for the hospital at home services that create value opportunities. So in a way, that set of stressors has prompted some change that might not have been experienced along the way otherwise. Thank you very much.
Yeah.
Speaking of payers, let's move over to Lloyd Kapp. Lloyd, you're another payer for us at Anthem and Blue Cross Blue Shield. What do you have, Lloyd?
Yes, I'm with Blue Cross Blue Shield of South Carolina, and we've been busy. You know, we've been working with our low value kind of group for about 3 years now, but we really over the past year kind of moved to bring it really external and really promote it to not just our providers like we have been doing, but to try to promote it to our members as well as our employer groups. We even renamed our group. It's now called Ask, Always Stay Knowledgeable. And we created a tagline for it, improving care through conversations. And we kind of thought through this by trying to really look at ways to get our members, employer groups, and providers to discuss, you know, issues surrounding care, what's needed, the importance of getting the appropriate care in the appropriate setting at the appropriate cost, and really looking at what is needed and necessary care as opposed to what is unnecessary or potentially low value, wasteful care, and kind of bringing that to our members, bringing that up to our employer groups, and not just the provider groups, where we had been focusing initially. Our focus had been on our provider groups and working with our value-based contracts and rewarding excellence programs within the state towards the provider groups. And so we've really kind of pushed that to try to help, you know, through social media contacts, through various letters that go out to our members to educate them on the idea of low value care, what low value care is, to ask questions with their providers and so forth, and to really kind of move it in that direction as well.
So Lloyd, you're using different media, different sets of media to reach a broad swath of stakeholders in this thing. You mentioned several out there. So a lot of this may have to do with how you convey messages to whom and so forth, right?
Correct. You know, we're using stuff through Twitter, Facebook, our blogs, especially, you know, we have a lot of members that are involved with our blogs. We have member letters that go out, so we're trying to educate them through those that go out like on a quarterly basis, and just to educate them on low value care, what it is, how to bring those questions up, you know, to their providers in terms of is the testing necessary, you know, how much does it cost, what happens if I don't get the care, you know, and really ways to bring that up and discuss it with their provider.
Excellent. Thank you very much, Lloyd. Great point. By the way, if you haven't seen it, you got to check out Joe Miro's comment about logarithmic scale of weapon systems and the value of reducing low value care from individual devices to missiles. Joe, I never would have predicted that. I believe every word of it. And I admire the math you got there. Great case example of making the case. Thank you very much. I see Matt Bartels is back up. What do you have, Matt?
Hey, thanks, Cliff. Lloyd did a great job describing where we're at. The other thing I was going to add, you know, we are at a payer, so we have a lot of data. And one approach we're taking is to migrate from just isolated measure creation to leveraging our data to look at variation, to lead us to those opportunities for low value care. And generally, we expect and anticipate to see outlier behavior, unwarranted variation among the large network of providers we have. So, you know, maybe at a future meeting, we can update you as to how that is going, but we're very interested, number one, to target the right providers, and number two, to really start to target things that have a bigger impact. And we know that high volume, low cost services add up over time, but there's also still a lot of high cost, low volume care that we need to address as well.
Matt, give us a hint. You're going to be looking into this. Do you have any sort of projection or forecast or idea about what this might reveal?
Not yet. I mean, well, I have ideas. You know, traditionally payers use other levers to control costs, like UM and prior auth and that type of thing. Our whole mission with our task force is to really drive provider behavior change and member awareness, as Lloyd highlighted, and employer group engagement. But so, you know, we're coming at it from a different angle than the traditional type of approaches that payers take, although we still use those and see value in PA and that type of thing. But to invest in this for the long haul, we hope to identify things that currently aren't being tackled through those approaches, and perhaps develop programs or incentives to drive down the variation, number one, but also to eliminate the waste that we know is there.
That is such a great point. No one likes prior auth. And if there's a way to kind of get it, kind of minimizing low value care and increasing high value care without having to deal with prior auth, I think you'd have a lot of people welcoming that. Thanks very much, Matt. Great point on that.
Sure.
And by the way, Muna Banji is asking, are we seeing a shift in reimbursement rates such that high value care is better compensated versus low value care? Matt or other payers, any comment on that? Are we moving at all towards kind of jacking up some reimbursement for high value and kind of knocking it down a little bit for low value care? Any comments on that?
I'll take a stab. It's a great comment, and one that has been kicked around. I don't think we're there yet, but absolutely it's going to be on the list of interventions that we could deploy in the future. We do things like create incentives for the members, you know, and all payers do this, right? To choose sites of care that are lower cost and higher quality. So there, in various ways, there have been incentive-based approaches to driving people toward higher value providers or centers of care. But specific to services and compensating differently, no, I don't know that that's happened broadly, but I love the idea.
All right, well, let's keep that issue on the table. Thanks. Mike Madalena, you've done a lot of consulting in this field. What do you have to offer at this point, Mike?
Yeah, Cliff, I would answer that question is yes, it is definitely happening in terms of reimbursement systems. We're looking long and hard at really whether it's directly or indirectly through site of service differentials, site neutral payments, attacking specific services through reimbursement models. Absolutely. I want to see more of it. It's, you know, I would, you know, it's been sort of a very much of a stepwise process, but seeing more and more of it, especially over the last several years with COVID. We're, you take the assumption that 2 to 3% of spend is low value on large employer plans, large health plans. I'll take 2 to 3% any day of the week. So I think this is happening. It needs to happen more, and we need to create more incentives.
Sounds good, Mike. Great point. Well taken. Any further comments, I'll say, from our employer community, whether you are on either side of the employee or the employer side, or if you consult with employees or employer groups on that. And I see Karen is up here. Karen, do you have a comment along those lines?
Hi, I keep getting thrown off the Zoom, so now I'm just on the phone, so I apologize if anything I say is repetitive to what others may have said. I guess it was at the last meeting we had of this group, or perhaps the one before that, I talked about how we've been working in the biosimilar space to really get uptake of biosimilars, and some of the health plans have made decisions to go ahead and promote biosimilars as a first line of therapy. And we have run into so many challenges with being able to see uptake even after those changes go through, whether that's at a provider level or, you know, gaps between when that happens and when the patient knows what to do to get a new script. So we've really been in the weeds on that, because it is not high value care when the patient shows up for an infusion and they don't have the right script for the biosimilar. So we've continued to do a lot of looking in the data to see what's happening, and also doing focus groups and working with the providers. So, you know, hopefully we'll have some more, you know, I don't know whether we're going to call it a guidebook, but some kind of reference document for the employers to be able to really make sure they're covering all the bases as they promote biosimilars from the reference products, because the patients seem to be left holding the bag. They're not knowing what to do on their end. The outreach, whether that's from the provider or perhaps the health plan or the employer, just isn't cutting it. So, you know, really putting a lot of energy into that right now.
Karen, very glad you brought that up. Oh, go ahead. Next point.
No,
Karen,
I was just going to say, and especially in light of the fact that we do have a number of new products that are in the pipeline, we got to get this figured out sooner rather than later over the next, several months, so that, as the new products roll out, get all their approvals and what have you, that the employers know exactly what, needs to happen to see that uptake.
Very glad you brought up biosimilars. It is a complex sector. My gosh, there's some gaming in the system, a lot of things going on insofar as how package deals are made. It's not just sometimes the biosimilar, there are other drugs thrown into the deal. And like I said, there's some interesting gaming in the system, but there's such a great unmet opportunity there in biosimilars to Chief's importance. It's something to clearly watch. Just as a side note, I know that the Academy of Managed Care Pharmacy, AMCP, is doing a lot of work on biosimilars as well. So thanks very much for raising that. Let's go next to Josh Fangmeyer for a view, a state view. And I see Mark Weinstein in the queue as well. Josh, you're up.
Hey, Cliff. Great to join you and be in these meetings again. It's always great to learn from all the other stakeholders.
Yep.
Yeah, so for Minnesota perspective, we've been working as part of what we're calling a high value task force, so pilot program where we have 9 employers across 4 TPAs contributing data and running the 3M potentially preventable event algorithm to understand. At this point, we're really digging into geographic variation, which is always a big topic in Minnesota. We have a lot of very rural critical access hospitals spread all over. We have the Mayo Clinic in southeastern Minnesota. We have systems in the Twin Cities. So especially for employers who have a workforce across the state, like we do for the state of Minnesota, it's just really important for us to get a handle on geographic variation, and especially these service lines where there's wide variation in use, and not just like on the overuse side, but potentially underuse as well. You think of like, hemoglobin A1C tests and important lab panels for people with chronic conditions. So there's some really interesting work. We're still in the really early stages, so there's not a lot that I can talk about, but it's been great to take an emphasis on the geographic variation side.
Yeah, Josh, Minnesota is such a good example. We've mentioned already Virginia, of course, and other states. It's kind of a big laboratory, and in Minnesota's case, a large flat laboratory for geographic variation. And I know that Q brought that up earlier in our discussion with regard to rurality and so forth. We want to follow your work, Josh, because maybe in subsequent meetings you can report back on what we're learning about that. A really important area to explore. Thank you. Mark Weinstein, thank you very much. Mark Weinstein, you're up out of the state of Florida.
Hey, can you hear me?
Yes, we can. Mark, go ahead.
Nice to see you all today. Effective April 1st, we're going to be licensing from Embold Health their high performance physician network in 9 specialty areas in cardiology, endocrinology, gastroenterology, obstetrics, ortho joint, pediatrics, primary care, pulmonology, and spine. And what Embold Health is going to do for us is identify the top 40% of physicians in each of those specialty areas in each of the 6 geographic areas in Florida. And we at IQBA are going to steer our members to go to those high-performing physicians by offering the opportunity to see those physicians at no copay. So we're hoping that this brings the right care with the right outcome and the right price, and does it all with a carrot to steer our members to high-performing physicians, as we all know really run the whole process.
Mark, great point. And the idea of to whom are you making the steering, and that is you pick some pretty often costly specialty areas. So there's a lot of money riding on the table there. Mark, please remind folks, not everyone may remember whom you represent, a special set of populations. Mark, can you recast that, remind us?
Right, so we're a MIWA, a multiple employer welfare arrangement in our 19th year, providing private Florida education employers with with 16,000 members to provide together health benefits in a way that individually wouldn't be as easy to do.
Thanks very much, Mark. I mean, you really have the colleges and universities under your wing there. And once again, it's a special population, not fully representative, but it has its own special considerations. And thanks for telling us about how and why you're making this steering in those specialty areas. Up next is Gwen Darien from NPAF. Gwen.
Mute and video. Hi, great to see everyone, sort of see everyone. I miss the hugs. We have got to get back. I've been hugging asking random people if I can hug them on the streets. Of course, mask on. Anyway, I just wanted to give, I wanted to give a little patient advocacy perspective on this, which is, and so one of the things that many patient advocates have been working on along with our organization, and it has been propelled a lot by COVID, are how you create public health messages that actually get people to high value care. We've seen the incredible downside of public health messaging during COVID, and particularly, there's things that are still unclear, but we as a community are all of us as a larger community are not good at communicating uncertainty, evolution of scientific evidence and aspects like that. So I think that is very related to eliminating low value healthcare, as well as promoting high value healthcare. And one of the places that I've been doing a lot of work recently is on high value and low value cancer screening, and what that means, and what it also means, not just the screening, but what happens once someone is screened, and what are the barriers to getting people to screening. And so those were just, I just wanted to mention those two things, because I think it's a really important context to put around a lot of the things that we're doing. Is it not just about developing initiatives, but it's also making sure that those initiatives have a dissemination and communication aspect to them that changes the healthcare ecosystem.
Well, Gwen,
including patients.
I'm so glad you brought up that point with regard to messaging. 2 points in response. First, you echoed the aspect of cancer screening diagnosis has been delayed and so forth. There will be some pretty tough downstream effects on that. But just as important, if not more, and this is probably for a later discussion, maybe even an entire task force discussion, is you as a patient advocate are probably seeing and feeling the effects of misinformation and disinformation in the healthcare sector. Like there's a whole nother other thick layer that you got to get through now, whether it's on screening or immunizations or anything else. Do you want to make a quick comment with regard to whether you're seeing any of those impacts about mis or disinformation? So,
well, just to go back to your first point about delayed screening, it is actually, we'll see, there's in the cancer community and in a lot of the forums that I've been in, people talk about the potential of having a lot of people patients present with very late stage cancer. But the other side of that, the corollary to that, is that people are also skipping screening that is low value. And it'll be interesting to see what impact that has. In terms of misinformation and disinformation, yes, we see that all the time. It is the calls that we get at PAF and NPAF are range from, they range the gamut of what you would expect. What I've sort of thought about it more from a system point of view, because the part of the misinformation has been about vaccine hesitancy and who is hesitant. And we talked about this a little bit before. And there's more and more research about how it's regional, how it's political beliefs, which also are, the anti-vaxxer upper middle class moms. There's a wide range there. But one of the things that we try to do as patient advocates is help people, prompt people into dialogues and questions that help them make decisions that align with their values, but also with public good. And so I think that's what we've seen in the pandemic, is this framing of things as a personal choice, and the loss of a frame that's not that. I mean, there's a frame that's been scolding about public benefit, but public benefit is we're not just individuals. We are living in a community, we're living in a society, and we have obligations, moral obligation to those societies, but it's very difficult to deliver that message in a way that is open, as opposed to kind of closing down and scolding.
Well, it's directly relevant to the discussions that we've been having, because if what we're trying to do is steer individuals in the system away from low value and toward high value, that's been hard enough. And if you get all this disinformation raining down on you, it just makes it more difficult. So yet another challenge. By the way, Tracy from Eustis came back on, had a great answer to that question about trying to kind of bridge that gap between a lot of the incoming military personnel that may be subject to disparities, but having that countered by universal coverage available through the system. So Tracy, we really appreciate you getting back to us on that point. It's in the chat. We have a few minutes left. I just want to kind of call on our pharma bio device folks who are on. If anybody wants to raise your hand about things you're seeing in your sector. I know we had a comment earlier about biosimilars, but anybody from the pharma bio device sector that wants to make a comment about what you're seeing with regard to low value care or related services. Take a look here. Muna's back on. Thanks for raising your hand, Muna. You've been looking at this for quite some time, including your time at a well-known pharma company. Muna.
Indeed. So I'm just going to touch on just a couple of things that strike me as I'm listening to this conversation. The first thing that I would say is in the whole discussion around the value of medicines that continues to be discussed not only in Europe, but also on this side of the pond. From a policy perspective, the pharma the industry continues to highlight that the focus should not just be on the 15% of healthcare spend that goes towards medicines, but that if we are going to have an honest conversation about the spend of healthcare in this country, we have to take a look at how we spend the remaining 85% as well. And included in that 85%, we all have seen the numbers, 20 to 30% of that spend is inefficient spend, inclusive of low value care. And so I think that's the voice that the industry continues to put out there. A couple of other things to point out. I was really struck by the fantastic discussion around the shift from hospital to home. And I would add to that the broader discussion of technology and how the adoption of technology, not only in remote care, but also being able to use the technology to lead to preventative care, I think can also go a long way in ensuring that high value care is brought into the system. So that is another piece that the pharma industry will continue to watch as we bring medicines to market paired with technology as well. And then the last piece, I come to this discussion as well as a board director on a genomics the diagnostic of the company as well. And I would just say that there is continued evolution of the science, bringing the diagnostics, the genomic, the diagnostics to cancer, the patients, to make sure that we are able to decipher which of the patients or to just be watchful, like waiting types of patients, and which ones in fact need to progress to more invasive care. It used to be everybody would be worked up with very invasive care. And now I think we have more of this precision being brought into the decision making. And my hope is that over the coming years, we will see this continue to be stepped up. And I think that will also be able to help us in getting after care that is very inefficient. So I'm going to stop there.
Muna, thanks. And we don't even want you to stop sometimes, because every time you have something to say, it's great. You made 3 great points, the 15% versus the 85%, moving a hospital into the home. In fact, matter of fact, there's hospital in the home technology that's enabling doing hospital-like care in one's home. The movement in genomics. Someday we'll have an interesting conversation about next generation sequencing and who ought to be sequenced and what do you do with the data and all that. It would all be great. Thank you so much as always, Muna. Ali Lapidus from Pharma. What do you have for us, Ali?
Hi. So hard to follow that because that was really great and a great summary of especially where the industry is. But I also really appreciated that we brought up biosimilars. Obviously, biosimilars are extremely complicated, especially when compared to like original brand versus generic conversations. But I think something that's getting more attention recently, especially with some more transparency data, some things like that, is that we're starting to see that it's not complete. It's a really difficult conversation. We're seeing, you know, there might be some financial incentives for hospitals to continue prescribing the originator product. So we're doing more work into that and kind of seeing what's really driving this, as well as, I mean, to add like another couple projects that are very unrelated. We've also are doing some work with Mark actually on the intersection of low value care and health equity, which is another thing I think, as we talked about at the beginning of this call, really needs to be focused on. And finally, the last thing I want to flag for this group is that we're also really excited that we've been, you know, continuing our work on low value care, continuing that push, but also that our companies have started to really want to be on the forefront of this. For the companies that weren't already, there already are a lot who are on this call. And so we're excited that this is kind of getting more focus, especially at the federal and state level.
Thanks, Ali, very much. And I'm glad you're kind of looking at those issues. It's good to have pharma and your member companies focused on this for all the right reasons. And I think we really appreciate, as always, your input. Our last comment before we're going to move over to Chernu in a second is from Dave Merkin. David, what do you have for us?
So I'm not sure if this is the right spot in the meeting, but it's really a report back to the membership. A couple of years ago, there was a presentation and a challenge to myself and my Millman MedInsight colleagues to add cascades to our health waste calculator, which is the Choosing Wisely tool. And I just wanted to report back that that's been done and is in our next release. So those of you who are licensees, and many of you are, that will be available to you. That was it, Cliff. And I
David,
wanted to show the picture of Rhode Island again.
It's okay. Not everyone's familiar. Just give a sentence or two background on the reference to cascades and so forth. Remind us.
Sure. So I think most of you know that Millman MedInsight produces a grouper that we call the Health Waste Calculator that is based on Choosing Wisely and other nationally recognized organizations that recommend, that basically define low value services. And cascades are when a low value service is delivered and it leads to ongoing services that would not have occurred had the waste service not been delivered. And we were challenged to add that to the tool. And we have for all the waste measures that were able to do so. Some were unable to do so, but anyway, so is that good enough?
It is, David. Thank you so much. And I remember when that kind of charge was pointed in your direction, and it really fills out the story so much better when you can go beyond the index service itself to all the knock-on effects that you've now termed cascades. It's a really important addition to the calculator. Thank you so much. Okay, my brain and my notes are overflowing all this great new stuff. This is wonderful. We're now going to switch to our dear colleague, Mike Chernu, professor out of Harvard Med, and Mike's going to talk a little bit about some updates, i.e. regarding evidence, policy, and practice. Over to you, Mike.
Yeah, Cliff, thank you so much for having me. I guess thank you all for coming is really the point. I have to say, I go to a lot of virtual meetings. It's almost impossible for me to predict how they're going to flow. The level of energy we've had here this morning is really terrific. And we're going to have two great presentations after. So I'm going to go through this somewhat quickly in the interest of time. First, I want to talk again a little bit about some of the evidence. I'm going to present someone else's paper, but I think it's useful for you all to be aware of. You'll see why in a minute. So it's always a challenge to present someone else's paper. I'm going to do it briefly, but can we go to the next slide? This is a paper by my colleague Ashani Ganguly. You may remember she presented, I think in our last meeting right before COVID, on her work on care cascades. She and actually Meredith Rosenthal, who's speaking after me, are I think some of the national pioneers in research on the care cascades, essentially the downstream effects of doing unnecessary testing, which has been a big focus of ours. And Carrie Cola, who was at Dartmouth, but now she's at the CBO, and they did some work looking at low value care at the individual healthcare systems. Can we go to the next slide? So they had a simple objective, which was to investigate variation in low value care across healthcare delivery systems. A lot of work, and several people mentioned work in geography. Geography is actually very important, but again, I think what's clear in some of the discussions here, I think it was actually Matt was talking about this. Some people from South Carolina, but I'm sure everybody does this. I know that John Keats at Cigna does this. I'm sure the folks at CVS Aetna do this. The connection to the providers ends up being crucial, and so understanding that variation in low value care at the provider level really matters a lot. And so they ran Medicare claims through the Health Waste Calculator, which is the measurement tool that Milliman has that David was just talking about. They developed 5 other measures they had to code themselves. I can tell you, having spent time on a project where we tried to code things ourselves, it's a real challenge, but they did it for at least 5 things. And they looked at low value care across the health systems. So next slide. Basically what they found was there were 40 across each of the 41 low value services. They found a range of 0% to 28% of beneficiaries were getting that service. And the most common were preoperative lab testing, which again fits very much into this care cascade work that Ashani spoke of in the last time she spoke to the task force. And what a lot of folks are interested, I know Beth Bortz in Virginia are focused also on some preoperative testing work, but PSA testing, antipsychotic medications. Notice the nuance of several of these. Some of them are simple in terms of the age, like men over 70, but others require some more complicated analytics to understand. It's not just use of antipsychotics, it's combined with certain clinical traits. And I won't go through that much more being an economist, but that nuance I think has been a theme of all of our low value care work. So they found a lot of low value care. Next slide. The real value was the variation across the different delivery systems. So these are delivery systems with composite measures, and you just see an enormous range of the proportion of eligible beneficiaries receiving component low value services. So, I mean, look at the top at lab tests. You see some that are just dramatically outliers, but even the quartile ranges, which are in the shaded box for lab testing and drugs, are actually pretty big. And so there's a lot of variation across providers. Providers do perform differently on the extent to which they can reduce the use of low value care. The next thing that the paper did was try and look at, you can go to the next slide, look at traits of the delivery systems where more low value care was used. So they found more low value care when there were fewer primary care physicians. Another way of saying that is when there was more primary care physicians, there was less low value care. So that's point 1. 2, they found more low value care in systems that did not have a major teaching hospital. So major teaching hospitals were associated with less low value care. They found more low value care if there was not an ACO. So meaning that having an ACO was associated with less low value care. That's a finding that fits with some other work that Aaron Schwartz and my colleagues at Harvard, Mike McWilliams and Bruce Landon did as well, that payment reform actually getting the incentives aligned doesn't guarantee you'll get rid of low value care, but certainly aligning incentives has been shown to help reduce low value care. Mark has a common line. It's hard to get someone to do something if they're in their financial incentives not to. That doesn't mean that financial incentives drive everything. It just means when they're misaligned, there are often issues. They found more low value care when there were more non-white patients. So this will fit into both the disparities conversation we had and the disparities conversation we're about to have. But someone asked earlier the issue about disparities in low value care. And again, as Q asked, there's a whole lot of different dimensions of disparities, but at least on the dimension of race, they found that the systems that served more non-white patients had more low value care. They found more low value care in the South and in the West, at least systems headquartered in the South and West. And they found more low value care in areas that had higher healthcare spending, systems in areas with higher healthcare spending. I'm not sure if you find any of these surprising. I think one of the challenges has been documenting things that we all have a sense of. I'd like to take credit for this paper. I really didn't know anything about it until I saw it on Twitter. Then I could talk to Ashani, but I think we're getting to the point where we understand both the variation in low value care across systems and the correlates of the systems that are doing better or worse. And I think the challenges for most organizations is to actually find the right levers and ways to partner with those organizations to reduce the use of low value care.
Mike, before you go on,
yeah,
I may be off base, but I think this is a really important slide. You're showing in these half dozen bullet points some things that many of us kind of wondered about or suspected. When you kind of walk down each of those 6 points, it beautifully illustrates the intersection of disparities and low value care services. I think this is really a sentinel set of points here that will help us make the case to our own organizations and beneficiary populations and providers about why we can't not pursue this issue. Mike?
No, I agree. I wish I could, honestly, Cliff, I wish I could take credit for it. It's always more enjoyable to present your own work. This is Ashani's work and a bunch of colleagues. But the reason why we wanted to carve out the time to talk about it was because I agree with you. This is something we felt that the members of the task force should see, because most people are very busy and they don't have the time to scour all of the literature. So that was my intent. And of course, there's other findings, by the way, in the paper. These are the ones that I distilled for this slide, but I encourage you, and we can send it around, Mark, we can send around to folks actually a PDF of the paper. So for folks wanting, and if you really want to, well, Meredith, I don't think Meredith is on this paper, although honestly, I'm not sure there's several authors, but Meredith certainly will know about it and talk about it. Meredith is one of Ashani's primary advisors. Anyway.
Well, here's the thing. Let's make sure that everybody on this call has access to the paper, whether we pop it into the chat or provide it somewhere the way before the end of our afternoon here.
It's already in the chat. It's been in the chat, actually.
Is it from Jordan? I'm trying to figure out where I'm seeing it from.
From Jordan's be putting all the key papers in the chat.
Got it. Okay, there it is. I see it from Jordan.
Okay.
Okay.
So let's go on. Let's go on to the next session. Oh, actually, I'm sorry. There was one other point to make here. They looked a lot of correlation within the systems, and so they found that there was some correlation. For example, there's a correlation between cardiac screening and head imaging measures, which suggested some system factors like screening protocols and capital investment, but the correlations were generally modest. So they write, and again, this is their words, not mine, heterogeneity in low value care provision was not surprising given the diverse drivers of these services and is consistent with studies showing limited correlations between quality measures. In other words, it is not the case that if you're doing more low value care on some measures, you're doing low value care on all measures. There's some heterogeneity. And then they talk about this, saying that there's some aspects of low value care where systems performed well and others where they performed poorly. So there was this sort of unique low value care footprint, which is what they were measuring. Again, those are their words, not my words. If you're particularly interested, we could have a Shawnee come back and talk or say more about it. But I wanted to give you guys a thumbnail notion that there's a lot of low value care. It's correlated with some factors that are interesting: payment reform, racial disparity, other types of things. But it is not the case that a system is good on everything or bad and bad on everything. There are actually unique footprints that are worth some attention. So I think that's my last slide on Ashani's paper.
Okay.
Next slide, let's see. Yep. So I'm going to switch gears to another paper. This is one that I participated in. There were, I wrote this with Mark, Francois Debrant from Signify, and Jeff Levin-Schurz, who I think is on. There's a lot of people on. I can't see Jeff, but he was on. He may still be on. And Jeff, if you are on, I may ask you to say something as I go through this. But we were, another theme that we've had on the task force has been what we call peanut butter and jelly, or PB&J, using both benefit design and payment levers to try to manage low value care. And of course, payment is really a broad term to refer to a whole slew of supply side initiatives, things aimed at providers, and benefit design is really a broad term used to define a whole bunch of initiatives aimed actually at patients. But in any case, I'm just going to say very few things about it. So can we go to the next slide? And again, there's several people who have reviewed this. Jeff was a co-author. He may want to say something. So one of the things that we've realized, and we did some early work on this actually with GE, that showed that when physicians are in alternative payment models and they have various quality targets, it's sometimes hard to meet those targets if there are significant financial barriers to their patients to access those services. So for example, there's going to be a lot of targets around diabetes, a lot of targets around heart disease. There's a significant equity component of that. For example, I'm the vice chair of the connector. We just had our meeting this morning, if anyone listened. Everything we do with the connector goes through an equity lens. And one of the initiatives to make that concrete was to try and lower cost sharing for services used disproportionately by disadvantaged populations, particularly in chronic diseases. We started with insulins. There's a lot of particular challenges in the insulin market, but the point is this is a broader point. If you want people to get their cancer screening, if you want them to take their chronic disease medications, if you want them to do a whole range of things to improve their health, they are deterred when you put large financial barriers in front of them, like high deductibles. And it has been a crusade largely of Mark's. I'm kind of like the sidekick. But to try and make sure that we don't put financial barriers in front of people when they are facing trying to access high value services. In fact, that was in many ways the original motivation for value-based insurance design. It had a sort of strong equity lens where we were very worried that populations were going to be hurt by high cost sharing for really important services. So we write a little bit about that. And now the question is how to bring them together. So I'm going to go through just some quick recommendations. So there's a lot in the paper. Recommendation one, obvious, keep cost sharing low for high value services, especially those designated as provider performance measures. Two, measure and report low value care and increase cost sharing for services where even patients have some control. That bit about the patient control is important. You don't want to charge people a lot out of pocket for things that they have no way of controlling. So I actually personally, and I can let Jeff or Mark chime in, I'm not a fan of relying too heavily on cost sharing to reduce low value care, because I worry that patients simply don't have the wherewithal to respond. There certainly can be some cases where that might, where aligning might be helpful. Recommendation three is hold carriers accountable for procuring high value services. I think that should be obvious. Almost everyone I think on the Zoom is going to say that they try and do that anyway. I agree completely. And hold carriers accountable for decreasing utilization of low value services. Also one for which I think a lot of people are doing. I will say one of the most encouraging things about these meetings to me is to hear all the energy going on in the carrier space to try and do these things. I must say that, and maybe I didn't have enough vision, but 5 or 10 years ago, I did not see the same energy on the carrier side to reduce low value care as I see now. And I still think there's a way to go, but at least there's a lot more energy. And certainly we have the leaders in many of the organizations here today. If there's time, when we have time at the end, I'd love to hear people's thoughts on it, but I'm going to kind of breeze through it now to get to the recommendations for policy, just because I want to make sure there's enough time for Meredith and David. Actually a few more recommendations for employers, and then we'll get to the recommendations for policy. We recommend that employers contract with carriers or third-party companies to improve patient steerage to high-value providers. Many of you are doing that, so I hope the employers all listen to us and reward you in the marketplace for doing the right thing. We recommend that employers contract with carriers to move to advanced forms of value-based payment where appropriate. In other words, where they're trying to promote value. Again, I think to move the system, we need to have the purchasers reward the carriers who are doing the right things. And to contract with carriers that seek to align fee-for-service reimbursement with the value of care delivered. Again, there's a lot of different things that carriers could do, but this came up earlier about Mike Madalena, I think, mentioned efforts by folks to reduce the rewards if people are delivering low value care and incent providers to deliver high value care one way or another. Next slide. So these are the policy recommendations. The first one is to define a set of high value services which providers may receive payment and bonuses that might be covered pre-deductible by health plans. We have some of that in section 2713 of the ACA, which Mark had his fingers all over, but we have noted repeatedly that there are services beyond things that the U.S. Preventive Services Task Force would recommend are high value, particularly chronic care management services, that we would like providers to have the flexibility to cover underneath the deductible, and the HSA rules have been an impediment to doing that. There's a lot of complicated nuances, and in other meetings, Mark could talk your ear off on what we're doing in that space. Implement regulations such as Affordable Care Act Section 4105, which allows the elimination of payment for specific low value services. Again, I'm not going to talk a lot about Section 4105. Mark can chime in, but essentially we're trying to amp up the incentives to do more high value services and fewer low value services. I see Mark flashing on. Recommendation 3 is encourage payers to report the percentage of spending in alternative payment models by model type. Well, we think that's true. And 4, before I answer, I think I saw a question from Q. I will try and answer your question in a second, Q. Or maybe I should let Cliff manage all the questions. But in any case, re-equivalate the RBRVS fee schedule, the Medicare fee schedule, to increase payments for underprovided high value services and lower payments for lower value services. Again, the fee schedule is hard to sort out, but that is where the recommendation is. Cliff, before I get on to practice, can I answer Q's question about primary care and specialty care?
Yeah, we got 2 points. Start with Q, and then Jeff Levensure's got a point.
Right. Oh my gosh, yes. Q, I'm going to answer you quickly. I want to let Jeff, my co-author, jump in from Willis Towers Watson. It is true that primary care tends to be associated with less low value care, and broadly it tends to be associated with lower spending and more high value care. So I am, broadly speaking, a fan of primary care. I only will point out that there is both high and low value care in both primary care and specialty care. And so we have tried to move the world a little bit away from thinking broadly around primary care and specialty care, although those as loose guideposts, I think they are accurate, as you say, to acknowledge that there is nuance within each. There's types of primary care that are really, really invaluable, and others that might not be as important as some specialty care. Likewise, within specialty care, there is a lot of specialty care, which I think would fall under the low value care rubric, but there's a lot of specialty care that we consider extremely high value. So the challenge that we have faced for decades is how to manage that nuance. I'd love to talk more about that, but I want to make sure that Jeff gets to say his piece. Jeff,
go ahead, Jeff.
Yeah. So first of all, thanks for inviting me to learn from all of you here, and I think Mike's gone over the recommendations, and just so folks know, my day job is I give advice to big employers as a consultant at Willis Towers Watson. I teach coursework on managing healthcare costs at the Harvard School of Public Health as well, and just I think that we've gotten really good at figuring out how to use incentives both to patients and to providers to increase the use of high value services. Not that we're still great at it, not that lots of people wouldn't be saved from dying of colon cancer if we did more colonoscopies, because those are true, but we actually know how to do that well. And I feel like our biggest gap is what can we do to decrease low value services? So that's why I'm, like, as I said, really thrilled to listen to the whole group. I think that lowering payment levels for low value services is going to be a critical element of this. And also just an observation that many low value services actually are high fixed cost services. And so the margin for doing extra services like this, whether it's MRI scans or vitamin D levels, the margins are very, very high. So the opportunity to lower unit prices there is, should be high. And obviously lots of providers make really good money on those things too. So just want to emphasize that I think that decreasing low value care will continue to be the real challenge. And to the extent we're effective at doing that, that helps make healthcare more affordable and helps be sure that healthcare isn't crowding out a whole lot of other very high value things besides healthcare.
Thank you very much, Jeff. That's great point. Mike, back to you. Mike, we can eat a little bit into our break time, but I think you want to watch the clock a bit. Go ahead, Mike.
Sure. Let's go to the next slide. I'm just going to do this very quickly to remind folks, in part because there's new people here. We've been trying to figure out how to reduce low value care and increase high value care for that matter. And we've acknowledged that there are a lot of different stakeholders that matter. There's purchasers, the employee benefit consultants, there's carriers, there's providers, there's beneficiaries. I'm sure there's others I'm leaving off, I apologize. Policymakers probably belong on this, for example. I'll keep academics off. But nevertheless, in listening to the conversation today, I'm always energized that all the work is going on, but I have to say, and I presented the last task force meeting, despite all of this work and energy, it has really been challenging to get widespread action or success in this space. And we have been struggling, maybe not struggling, we have been working to try and figure out how we could become bolder, push more with actual levers. So can we go to the next slide? We've been talking to a lot of folks, and I'm just going to raise a few issues. We're not going to have a lot of time to get into this, but you can certainly email me, or we can save it for the next meeting, or we can talk about it later if there's time. So the concerns we've heard amongst employers have been a few things. Everyone wants to know, what are the levers? But a lot of employers think it's really not in their purview to influence care. And sometimes they'll say the juice isn't worth the squeeze. That there's just not that they can't figure out how much low value care they can get out. Again, I'm not a fan of that view, but it is a view we've heard. The benefit consultants, and I will defer to Jeff. We have, by the way, Jeff's team has been terrific. We've been talking with Jeff and T, a person that works with Jeff, about some of the work they're doing and trying to find employers. But the employee, they have expressed a concern in general about their relationships with the carriers, which is interesting because the carriers, like here, have been quite enthusiastic in a range of ways, but we've heard that. The carriers, again, we hear a lot of enthusiasm among some carriers, but there are often concerns about their provider relationships and the extent to which they can really push the providers. The stuff that Beth is doing in Virginia, for example, is really a lot of work, and I think cutting edge provider engagement activities, and that really matters. And then, of course, there's a concern with the carriers about measurement. Is this really high value care or not? Of course, if you go to the providers, that's actually, I think, in some ways the most complex area, because no provider wants to advocate low value care. There's a lot of stories about high prices. No provider wants to advocate low value care, particularly when the low value care is coming from choosing wisely, which is really provider defined. But you do get a sense that there's a concern about revenue loss in a whole range of ways. It's not spoken of as much as I think it might be under the surface. Again, I could be wrong. I'm not a physician. I don't work in a health system. And again, of course, the providers worry about levers. How can they get folks to do things? So we, I don't know what the right phrase here is, for a lack of a better term, we believe that there's progress. I must say, coming to these meetings, there's more and more people and more energy, and thoughts about how to overcome these are champions, people that really want to move. And many of the champions are here with ideas about what to do and how to bring these groups together. I'm enthusiastic about what's going on in South Carolina for a bunch of very specific reasons, which could be a separate story. We can go from there. And Gwen, yes, you are completely right. There are patient group concerns in a whole range of ways. We have not, I'm glad you're here, Gwen, and it's really an oversight on my part. We have spoken and we do believe the importance of the patient groups, but you see a real challenge in a bunch of areas. I don't have the time to go into some of the comments around Helm and some of the other challenges in the healthcare system with where value is, but I think your point is spot on. And the more we could get the patient groups aligned, we had a very hard time at Harvard, for example, getting the employees aligned because they really did not believe there was a lot of low value care and they didn't want anyone influencing the care that they got, even if objectively it might not be efficient care that they should have gotten.
And Mike, can I just make one really brief comment? So
absolutely.
One of the other ways of getting patients involved is getting them, getting patients and educating patients about about potential harms of low value care. And we talked about that on the on one of the VBID summits. That was what I talked about. But a lot of patients can push back on their providers. I've torn up antibiotic prescriptions. I've resisted screenings that were not needed. So don't forget that as a lever, not just the concerns, but also the way that, the concerns in terms of not delivering care, but think about patients' concerns in over delivering care and how we can utilize that.
So Gwen, I agree completely. I will say I have been sensitive to using financial incentives on the patient side because of disparity concerns and because all the evidence that shows when you charge patients more, they cut back on low value care and high value care on roughly equal proportion. The extent to which we can educate patients and inform them and use other tools to engage them, I think is actually really important. This is a nut that has been particularly hard to crack, but I don't disagree with you in theory that people should both be in control of their care and they should resist certain things. But a good example would be antibiotics and how resistant that has been on the patient side. Innovations there matter. Cliff, yes.
Yes, Mike, interest of time, is there any final points you want to make here before we go to break, Mike?
Well, I'll just say a few short things about some things I saw in the chat. To Jeff, I agree with your comment about the South, although I don't know enough about it to say that with any certainty. It's certainly sensible. And to Karen, yes, I agree that this alignment between what's covered and paid for and the value is important, and how we build that matters. I do have some hope for alternative payment models. While I am a big supporter of health literacy, Denise, I think the challenge is that has been a really big, heavy list for a long time, and I think we're going to have to be a little more aggressive. Q direct messaged me about us being bolder. I am often accused of nibbling. I don't disagree with him, but we are trying to move in the right direction. And as we go forward, a lot of this, and I guess Q, when we talk later, is how far can we push CVS Aetna to push the providers as bold as we can be, because we will support you and as bold initiatives as you could possibly design.
A side conversation I'd love to listen in on. Mike, I think we're really uptight here for time.
Yeah, I'm sending it to Mark.
Good. Mark, do you have a brief comment now before break?
Under 1 minute. I went 2 hours without talking. So this is, I'm completely energized. And it's very exciting to see how the new members like Dr. Ree and Dr. Levin-Schertz have kind of slid in seamlessly into our 10th meeting in this regard. I do want to say, as we end on the low value care issue, that at least 4 people, Cliff, used the term that came out of meeting 1 called headroom. That yes. we're in this, of course, to be able to find more generous coverage for the things that all of us agree should be no-brainers. And I just want, I'll put it in the chat, but just briefly say that with work of the Smarter Healthcare Coalition on the call, Katie Spangler, AHIP, and I'm back on the call, our friend Paul Franzen, EBRI, we've recently surveyed employers and plans on their willingness and ability to improve pre-deductible coverage on those high-value services that Mike mentioned that were attributed explicitly in the IRS Notice 2019-45. And we found that 3/4 of health plans and 3/4 of employers surveyed mentioned that they did make a change in the services they allowed pre-deductible because of the efforts to rob low-value care Peter to ultimately pay high-value care Paul. So thanks, Jeff, for validating the work we've been doing for 30 years and the task force for 7. And we're going to just be bold and continue to work with all of you to help you, help us, help you, help us. So Cliff, I'll let you turn it over to the break.
We'll take the word bold for a go-ahead message, Mark. Thank you very much, you and Q. All right, because we are so anxious to hear everything that Cutler and Rosenthal have to say, I'm going to be the tough guy here and say we're still going to reconvene at 15 minutes past the hour, which is only about 8 minutes from now. Let's get Cutler lined up and we'll be ready to listen. Talk to you soon, everybody, 1/4 after the hour. So I think most folks are back. David Cutler, the Otto Eckstein Professor of Applied Economics at Harvard University, and many other credentials. David, when you are ready to go, we are ready to listen.
So thank you so much for inviting me. This is just a wonderful occasion for me to be with you, and I really appreciate it. I know a number of the names and others of the names. I recognize various issues about where people are from, and oh, wait, sorry, I screwed that up. Where everyone's from and so on. So I really appreciate it, the invitation. I want to first figure out how to use my computer, and then let me first check, because everyone has to check. Can people actually see the
Affirmative.
Can people see it?
Yes.
All right. So here's what I want to do. I want to start off. I'm going to do, as I mentioned, I'm going to do less talking and more engaging. And so here's the way I want to start off. I actually want people in the chat to write down a quick phrase about what do you find give me an example of low value care. And the hint is that I'm going to talk about administrative costs. So maybe let's just go to administrative costs. What administrative costs do you observe that you say, this can't possibly be good for anybody? Let's get rid of it. So can I ask people to do that? So I want everyone to write in the chat, what is an example of administrative costs that you say, this cannot possibly be good for anybody, I want to get rid of it. So people understand what your assignment is, yes? PA for necessary care from Manu. Facility fees, okay, excellent. From Karen in Florida. Provider portals that had no value from Karen in Washington. Mark and Mike, I don't see you weighing in yet. Site of service differentials. Okay, excellent, excellent. Very hard to argue, those offer a lot of value. Patient portals that don't provide information that is of value needed by patients. Much of the marketing expenses that are built into healthcare costs on the provider and plan side. Duplication of case management fees from health plans and coordination fees for providers, dealing with so many payers, preoperative testing for low-risk patients undergoing low-risk surgery. Billing issues that arise due to crazy complex rules. Yeah, of course, Mike Chernew knows a little bit where I'm going too, so it's no fair he gets to cheat on this. So these are all like phenomenally good examples, and I want to keep them coming. Development, circulation of educational provider mailers, especially fax, USPS. Yeah, as best I can tell, the only people that still use fax in the world are US healthcare providers. So while those are coming, let me tell you a little bit about what I want to do. I know this is a group that thinks about low value care generally. And I want to talk about a particular component that I've been interested in over the years, which is administrative costs. And in many ways, it's a little different because what I want to talk about is not provision of medical services, but of all the stuff that has to happen to provide medical services. Oh God, unexplainable explanation of benefits. Yeah, even when you think you know what it is, you can't figure it out. So every industry needs some amount of administration. You just have to have it. But the question is in healthcare, you know, how do we figure out which of it we should have and which of it we should not have? So so what I want to do is very, very briefly lay out the problem, but then talk a little bit more about explanations. And I'm glad to see that a lot of your explanations fit into where I'm going to go. So that's very good, because otherwise I would have a very difficult time. So let me lay out a little bit of the parameters, and then we're going to get into some discussion. So the US spends close to $4 trillion now on medical care, and it's estimated about a quarter is administrative spending. As I said, by itself, that number is not, you know, you need some administration in any industry, but the magnitude of that number relative to what it could be is, I think, where I want to go with this. You see the administrative spending happening in a bunch of different areas. Obviously, some of it happens in payers, and that's the sort of administrative cost that we often think about. But as people here know, the hospitals and the physician groups and other sources of care provision really also have a very big role in the administrative component. Q asks, what should the administrative spending be? Let me come to that just in just 1 second. What I'm going to tell you is that I believe we can save on the order of, you know, a quarter of the administrative spending, maybe $250–300 billion a year if we did it right, out of, say, close to $1 trillion of healthcare admin. But let me come there. I should say that the work on which this is going to be based, I did a paper for the Hamilton Project on reducing administrative costs in healthcare. I did that because I got interested in this, not because I understand the issues, which I don't, but because I wanted to just find out a little bit more. And so then I found out a little bit more, and I wrote one thing about it. And then, like, it's very hard to find people who like really understand it very well. And so I sort of got dragged into knowing a little bit more. I've then, since I got some friends of mine who are at consulting firms to say, look, can you folks take a look at some of these too? And so there's going to be a report coming out in a couple of weeks that I've done with some colleagues at McKinsey on taking a very, very deep dive into administrative costs and how do they, as a group that looks at different industries and different firms within industries, think of administrative costs. So look for that coming soon. But I won't go into too much of it here because it's you'll get a chance to see it soon. Okay, what I want to distinguish between, first off, are two types of administrative expenses. So I want to try and get our hands around the administrative expenses. And for lack of a better phrase, I'm going to call them within and between expenses. So within expenses are things that happen within one, entirely internal to one provider system, healthcare, physician's practice, insurance company, anything like that. Those are things like HR, finance, and so on. You know, this is the C-suite too big? Do you have too many people answering the telephones? Or, you know, is there a better way of doing the triage when people, you know, is there a way to set up a better website so people don't have to call as much? It turns out, and this is going to be a big part of the report with McKinsey, it turns out that when McKinsey folks sort of benchmark, like, you know, how big is the administrative operation, just taking care of the basic business operations, not even the healthcare operations, just the basic business operations of most healthcare providers, they find that they're bigger than are the administrative operations, the internal administrative operations of other companies of similar sizes. And that, you know, like one of their favorite examples when we would talk about it is like the call center is much bigger in healthcare than it is in an equivalent other industry and stuff. And that's because people can't access things in any other way. So therefore they're all using the call center and so on. So there's a bunch of within stuff. I'm actually not going to talk that much about that here because it's less, that's more of a sort of management science thing. And I'm not so much a management science person as I am an economist. So instead, I want to talk a little bit more about what I'm going to call the between expenses. So those are expenses that come when one party has to interact with another party. So claims management is the classic one here. Prior authorization, I think the very first comment we had from Muna, I hope I pronounced that correctly, is about prior authorization. Quality reporting, someone noted the quality reporting up earlier. I can't find the exact quote, but someone put it there. And of course, data interoperability, which underlies all of that. Those are things that I want to talk that I want to talk about, and they're all, the key to all of them is that they involve more than one organization, and that means there has to be some standardization in it. And one of the interesting things about that standardization is that in most businesses it happens like in a coordinated way. Like Walmart says to its suppliers, yes, we'll give you access to all of our data, and if you can find a way to make anything cheaper, then we'll all share in that. And in healthcare, it happens in an acrimonious way. Like we're going to audit everything you do, and then you're going to hire people to fight back on the audit, and we're going to hire people to fight back on the people that you've hired to fight back on the audit. And sort of the acrimony is very expensive, whereas other industries, it's much more of a sort of cooperative game than a non-cooperative game. And I think, and that's going to be one of the key things here. So I'm going to focus on these between expenses. So this chart people have probably seen. Some healthcare interactions are electronic. So for example, claims submission is almost always electronic. I think in some cases like mental health and so on, it may not be it's still not electronic all the time, but mostly it's electronic. The problem is there are things that are not electronic, particularly prior authorization, which is down there. And that's why probably that came up very early on in your comments, as it comes up all the time. And claims attachments, which are the things that insurers require in order to make sure that people that the billing is appropriate. So they say, well, here, of course, the claim submission is a required standard format, but the claims attachment we can do on our own, and that's where all the interesting stuff happens. And so that the fact that that is an electronic is a big cost as well. These things are very costly. Just to give you a sense, the estimates of organizations like CAQH are roughly that each of these events takes about $10 of time, say on the provider end. So it takes about $10 of time to do a prior authorization, about $10 of time to do a claim attachment. Some of them are even bigger. And so there you're just going to get these sort of huge costs associated with doing the with doing all of this. And then the other things that are electronic, even though they're electronic, they're still costly. So for example, programming all the computer things and stuff like that is all is all very, very expensive here. Okay, so let me just take one quick break because my day is, thank you so much. Thank you. Okay, so, so I was just taking care of one quick thing there. I apologize. Okay, so that's the so that's what's sort of going on, and that's where a lot of the expenses are. Many of these are in what are called BIR, billing insurance related expenses. What I want to I want to do two things. One is I want to be an economics nerd for a second and say, well, why is it that that these things have not been solved? And then second is I want to do a little bit more and say, how is it that one would solve them? The key point, I think there are really two key points here, maybe three key points. One is that in most organizations, they're solved by, in most industries, they're solved by a big organization coming in and saying, this is how we're going to do it. And so let me give you two examples. The first example is from banking, which is when you want to wire money. So let's say, Mark Vendrick is going to wire me, $2 million from his bank account into my bank account. So he calls up his bank and he says, please wire the money. The way that happens is that there's a standard set of rules that banks have to use when they want to transfer money. And those rules are set by the Federal Reserve and by a private clearinghouse that was created by banks. And the reason they did that is because they said there's no way we're ever going to be able to transfer money if we can't figure out how to do this in a standardized way. So there are rules that are set by an organization, and then the banks, if you want to play the game, have to do that. And everyone wants access to it, so everybody just follows the rules. So that's an example where a big organization came in and said, we're going to do this. The other example that I want to give, which is probably even more relevant to healthcare, is UPC codes. So those are the things when you go to the grocery store and they scan the barcode and then the price shows up. The UPC code is the same everywhere. So there isn't a different UPC code for Walmart as for Target, as for the grocery store. It's all the same. The prices may differ and what they carry may differ. One may carry 12-ounce cans and one may carry quarts, 2-liter cans or whatever. But the UPC code is the same. So therefore the manufacturers only have to produce it once. And then each of the stores can plug in their own price for it. Whereas in healthcare, it's kind of like if every insurer has their own UPC codes. They all require different things and they have to be standardized in different ways. And so what you submit to one insurer has to be different than what you submit to another. And what happened in the UPC codes is that a couple of stores just got together and said, that's lunacy. We want to save costs on our checkout personnel. And so in order to do that, we have to standardize things. And then they started this movement to standardize it. And now again, it's completely standard. Like you're not allowed to sell on Amazon unless you do that, or except if it's a customized product. Shipping containers, by the way, are the same way. They're all standardized, and and then they get on trucks in standardized ways, and just enormous cost expense. So that's the first sort of rule, is that you need someone big to be involved and coordinate. And then the second rule is it helps if someone is really paying the cost. And the thing about this that always strikes me is that providers bear very high administrative costs that payers don't pay for. Or to put it another way, payers don't get a rebate if they don't impose administrative costs. So, they can make a provider pay $10, sending over forms, but they don't ever get a break if they don't do that $10. So that's why you have, thousands of medical rules and thousands of pharmacy rules, because I, as a payer, never have to pay for it, and I can impose all sorts of burdens on providers, and I still, and that's just tough luck. Now, it could be that, in the next negotiation, it shows up a little bit, but it's very hard to make that case. And so what really happens is that, there's no incentive to get rid of it, because there's no incentive for any payer to say, which of these rules do I not need, because I'm not, or there's less incentive because they're not the ones who are then bearing the cost of sort of meeting all of that. So for all of those reasons, what we're going to need is some type of bigger solution. And that's why I wanted to focus on these sort of between costs, because they're really not just between, they're between two organizations, they're between lots of different organizations here, between all the payers and all the different providers. So what could you do about it? What I want to do is give 4 ideas. I'm not going to try and convince you that every idea is the right idea. But I want to give you kind of a sense about how to think about these sort of costs and where one would go with them. And then, as I said, at the end, I'll talk a little bit about, what can be achieved from that. And I think the answer is a lot can be achieved, but let me first go through the ideas. So the first one is something that we've been talking about that I mentioned earlier, which is to follow the banking model and to have a clearinghouse. And so the idea here is that, this is the banking model where if an originator, i.e. Mark Fendrick, wants to send money to a receiver, i.e. David Cutler, then the originator contacts, in this case, his bank, says transfer the money. That goes through an automated clearinghouse, which has a standard set of rules. And there are actually 2 different organizations here. There's an organization that sets standards. So they set standards for exactly what must be on the claim form, and like what numbers have to be here and what codes have to be here and so on. And this is the way you do it. And then second, but that they don't actually transfer the money; they just set the standards. And then the money transfer is conducted. Obviously, that has to be more secure, so it's conducted by these secure organizations down here. Just to give you a sense, we transfer about $50 trillion a year of money between banks, and we do it at a cost in the hundreds of billions of dollars a year. The money for setting up the standards is actually paid by a very, very small assessment on these folks here, on the depositors, on the different financial institutions, and those financial institutions, in exchange for that, they get help making sure they're connected, and they get all the latest updates on everything and stuff like that, so that nobody's spending a fortune on administrative costs associated with programming their computers to transfer money and so on. If you were doing the same thing here, you would you would sort of, I think, borrow the same type of technology. So only standardized transactions could go through the clearinghouse. And then on the one side, you have the providers, the health systems, hospitals, physicians groups. On the other side, you have the payers, Medicare, Medicaid, and private insurers. And the standards, you need a body to set that. It turns out there is a body that sets standards for administrative, for these things in healthcare. That's why claims submissions are standardized, because there's a body, CAQH, which does that. So that's already there. What you need to do is you need to standardize. You need to say, this is how we're going to do the transfer. This is what you're going to put on the form, and this is the sum total of what you can get, and get rid of the kind of claims updates. the sort of claims.
David, you're muted.
Oh, I didn't, hopefully I'm not muted, but.
You are not muted. The rest of us can hear you just fine.
Okay.
Yes, we're not muted.
Okay. Okay. And so the standards organization sets the standards and then the rest gets transferred. Then things get transferred. You clearly want to transfer more as opposed to less. That is anything that a provider would want to make, to be a part of payment, you'd want to transfer. But the key is that it would all be standardized. So it'd just be a single thing that you always sent through. And then you couldn't do anything beyond that. Or if you wanted to do something beyond that, you'd have to pay for it. So you'd say, look, private insurer, you can ask for information beyond that, but you have to pay $10 each time you ask for it because we know that that's roughly the cost of it. So that's the way that this would work. The biggest cost here would be one-time costs for computer updates, particularly for Medicare and Medicaid, probably in the billions of dollars, though I don't know that for sure, probably in the low billions, I don't know that for sure. Providers and particularly payers would have to standardize their systems to accept that type of information. So it would be one-time costs, but based on every projection I've been able to do, it would save money fairly quickly and then continue saving a lot in the way that banking has saved a lot. So that's the first one. The technology is there to do it. Like I've asked around a lot, the technology is there to do it. It's no problem doing it. It's just a question that we haven't done it yet. Okay, the second one is on prior authorization stuff. And this is somewhat surprisingly, it's not as big money. So it's not as much money involved there as, for example, money involved here, but the hassle is enormous. So there is no provider who doesn't absolutely hate this. And it sort of discourages practice and the patients hate it and so on. Here one could do similar sorts of things. So one thing you could do is standardize the prior authorization submission in exactly this way. And I think that would be valuable, although there's probably more variation in what the prior authorization has to do than what the billing has to do. I want to suggest a couple of other things, though. First is what I call simplification of existing rules. So one of the things that a lot of the organizations agreed upon, but hasn't really happened yet, is to try to simplify the rules. And a lot of these are, to just lapse into being an economist for a second or a nerd for a second, a lot of these are what I think of as non-linear rules. So the rules that are often applied are linear, like every time a bill comes in, I do X. And a non-linear rule is, no, maybe I don't do it every time. Maybe, at the end of each year, I choose 30 random claims and I audit them. Or for a provider who was really good last year, maybe I don't have to audit them at all, or I audit them very lightly. And in other providers that weren't so good or that I don't have much familiarity with, I audit more. So those go by various things called like gold carding and a variety of other things that are talked about, but not really done very much. I've tried to investigate why they're not done much. And the best answer I've heard, which is not really an answer at all, is that the insurer's computer systems would have to be reprogrammed and they find that hard to do. That's a very lousy excuse for not doing something. And I don't know if that's really the right one or if it's just that there isn't much of an economic incentive to go about go about doing that because it costs money. And if everyone else is still using their own their own different way to do it, that would be you wouldn't save very much. So I'm happy to build it into the price. I'm happy to require a price for it. But I think it's enough of a bother that we clearly ought to think about using those types of things. And also it's going to turn to something that I want to come back to in a second, which is the information flows. That is, why is it that the provider has to document this every time to the insurer when in fact the insurer could have a record of that information? So I'm going to come back to that as the fourth point. But the third one is on the quality reporting. The quality metrics here are, they're sort of all over the map. Lest you think this is all a private insurer issue, Medicare has some close to 2,500 different quality metrics. Nobody has totaled up the number in the private sector or by state and local governments, but it's got to be at least that amount. The key here is a couple of things. One is, again, the harmonization, the standardization. Remember, that's sort of the key to everything here is standardization. The other key, I think, is to choose measures that you can get passively as opposed to that you need to get actively. And that's another thing, another lesson from other industries, which is that when you want to get information, the very best way to get that information is to do it passively. It just happens. And when it happens, it gets recorded. That anything that requires active stuff to make work is just going to be frustrating to people. And so thinking about ways to do it passively, and that's going to mean going into electronic medical records, potentially into patient reports about how things are, but do it in a much more straightforward way. There have been examples along these lines. So I've yet to see an article on it, but I believe that Minnesota requires that all quality metrics, that all payers use the same quality metrics. I have no idea how that's gone or how it's been implemented or what exactly that extends to, but it's something that would be really good to know more about and to experiment with. So get the information where you need it, and then make what you do depend only on the easily available information are kind of the keys here. I would also try and do these quality metrics on the basis of total practice rather than just each practice by each provider for each individual payer. But I understand their costs and benefits of doing it that way. Okay, and then the fourth thing that I want to say is the data exchange. And this in some sense underlies the whole thing. So we have to get data from one place to another, and the billing, we've sort of figured out how to do it electronically, although it's not the same everywhere electronically. The prior authorization, we haven't. There's another economic issue here, which is that the EMR, neither the EMR vendors nor many large systems really want to share information, because when you share information, that makes it easier for customers to move from one to another. The example that I think about here is cell phones. When cell phones first came out, there was a dispute as to who owned your phone number. Did you own it, or did the company own it? Did like Verizon, the equivalent of Verizon, own your phone number, AT&T, or did you own it? And of course, the companies wanted to own it because they wanted to make it be that if you switched carriers, you had to switch phone numbers, and that would clearly lock you in more so to your current carrier. And in the end, the Federal Trade Commission said, no, that those phone numbers are going to be owned by individuals, which is why you're allowed to transport your number from one carrier to another. In healthcare, we still see examples where organizations, less so because of recent federal regulations, but you still see examples where organizations say, oh, yes, we have an electronic record, but it's only for us. And yes, you can look in it, but we're not going to give you any roadmap to show you where the information is located in the EMR and so on. And so you have a situation where, as a result, when you want to get prior approval, someone has to go and print it out from the record and Xerox it and fax it, and someone else has to scan it and read it in and so on, when that information should be transferable, in fact, is transferable electronically. Recent regulation has moved along these lines to try and require, so it now says to big providers, you can't keep the information hidden, you have to allow folks to access it. But it still hasn't gone far enough. So for example, there's talk about, should insurers be required to keep longitudinal records? If so, then the prior authorization becomes much easier because they may have all that information already. Or should it be able to query easily? So, if you want to do surgery on some patient for which prior authorization is required, you have to show that you've already tried medical management, make it easy for the provider's system to attest to the insurer, send over the information. Yes, we've tried medical management and it hasn't worked. Or better yet, just ensure that the electronic medical record system installed by the provider doesn't authorize the surgery until the medical management has been tried. And then you can say, yes, I can certify that all of our surgeries meet these criteria, and so therefore there's no problem with it. So all of that is are things that we could do more, but and we can do it by regulation, but life will be much better if we evolve towards a cooperative model as opposed to a confrontational model. I have a couple of questions and answers here. This is not going to be easy, but that much said, it's not brain surgery either. So nothing that's been on here is something that's not done in other industries or not routinely done in American business or not routinely done, in other places. So none of this is rocket science. What it is us sort of thinking through how are we going to get this done and then making sure all of this happens. As I said at the end, our best guess is that I think anywhere from $200 to $300 billion a year is there for the taking. I will note that I've had quite a number of conversations about this with other folks, including people from outside healthcare who are really eager to be involved. So I'm hopeful that there will be many new initiatives that come soon, either from federal or state governments or NGOs or other nonprofits that push along these lines to do things about administrative expense, because the longer this goes on, the longer it is that people pay too much and providers get frustrated and patients get frustrated, and there's not, and then we lose momentum. So I'm going to stop there. I probably went on even longer than I said I would, which I apologize for, but I really want to have discussion, and thank you so much.
David, this was splendid. You did not go on for too long. We could listen to even more. Just want to recap a few points you made that I know I've seen a lot of stuff in the chat, and I'm queuing up Q Ree here because Q, you made several comments, a few implied questions. So Q, I'm going to call on you first in just a moment if you don't mind, and then we'll be looking for raised hands. A few things, David. We very much like the distinction you made regarding the within versus the between. For discussion some other time, the within thing was really interesting. We'd like to hear more about why are we so off base on the withins as opposed to other industries, but that's discussed for another time. You clearly addressed so nicely those four kind of solution areas, which was kind of the banking ACH model, getting over the prior auth hassle with gold cards, et cetera, the quality reporting and the passive versus active distinction, and the data interchange. So those four models are all on the table. They all seem to be feasible. We're looking forward to something along those lines. And you kind of presaged some of the questions about single payer, about job loss, and about investment as a one-time. So thank you for framing that so well. With that, I'm looking for raised hands, but if Q, if you don't mind me calling on you, you made several comments, please go, Q.
Yeah, no, I appreciate it. And I'm just looking at the comments. Thank you, David, and just sequencing kind of from the beginning. And I love the simplicity of your four areas that you're recommending and the context you provided. I'll provide a quick commentary, but also kind of what I would view the real world challenges. So, I would say, healthcare is different than any other industry because of how fragmented it is and how many diverse stakeholders and how diverse stakeholders have different views of the data and also different incentives in terms of the outcomes that they're looking to achieve. So anyway, I do appreciate, my first question was is the $10 per PA? Because I agree with you that when we do prior authorization, we should be looking at the cost to the provider as part of our calculation. Is that $10 you referenced for the claim and the attachment, the prior auth and the claim? Is that a hybrid of, isn't it cheaper if it's electronic versus manual?
Yes, so, that's actually the estimated cost of a manual.
Oh, manual. So any estimated cost for electronic if we were to automate?
Oh, probably pennies.
Okay, that's a good thing. So we want to get to fully automated prior auths. And what about the claim attachment? That's that requires usually a PDF. Is that $10 still?
That's so CAQH does these estimates, and they range for various things anywhere from $8 to $15. So roughly per thing. So that's roughly about the range.
Okay, got it. But that's it. Like I noticed that the claim attachment was very low electronic in your graphic, and to me the scary idea, if you're mailing it or you're faxing it, that's not as efficient as electronic, right? So I assume those estimates are based on mostly manual.
That's correct. They are based on mostly manual.
Wow. Okay. Then if you go, I put the questions in the chat, sorry. Who would lead this? So CAQH is a nonprofit based in California that's been around since 2001. So if you have this claim processing data warehouse, is this going to be managed by them or who?
So if I just flash up that one slide here for 1 second. The CAQH would set the standards for it, but they would not be the organization that would physically do the going back and forth.
Right.
So you'd need to either borrow from the banking model. So you could literally take the same organizations. There are these two organizations that transfer money. Or you could set up a different organization. They're not that hard to set up, that then just sort of says, okay, every hour or every day we get the information and then we send it along and it goes out we have a big funnel at one end, it gets the information, it flows, and then the funnel opens at the other end and it goes to the relevant place.
Yeah, I'm just
So,
thinking I was just thinking CMS, because there's a lot of claims go through Medicare. I mean, I'm thinking of a national group that you would recommend that could be trusted by all the diverse stakeholders who have, different interests. And just if you were, part of me was intrigued if there was any legislation that talks about creating such a group in the federal agencies or government. But
yeah, I haven't seen it. In the case of money, there are two. One is Fedwire, which is the Federal Reserve, and they handle everything that involves government. And then second is there's a private thing which was set up by a bunch of banks, and it's called the Clearinghouse. And it's its own governance and stuff, but it's the board of directors is all these these banks and stuff. And they handle private to private.
Yeah, I mean, banking, to me, there's a simplicity about money that in healthcare, the challenge. But let me go to the next two quickly so others can ask questions. Prior auth. So look, I love the idea of gold carding. I hate the friction that exists between payers and providers, but ultimately it all comes down to the details of what the criteria are and how they can be agreed upon and all that. So to me, this gets the basic issue. I don't know, to me, banking and money, there's a clarity or a product that you get at Walmart, you know what you're getting, you know the ingredients. Healthcare is very different in that there's a lot of fragmentation, there's a lot of inability to see transparently things, and quality is, I would prefer, it's a personal thing. Some people care affordability is the most important thing. Some think equity is the most important thing. Some think effectiveness is the most important thing. So anyway, I'm curious, what criteria for gold carding has been effective, and what you would recommend. That to me is important. Do you have any criteria that you recommend for gold carding?
The places that I've seen it most are those with like centers of excellence. So you have a center of excellence in whatever type of surgery, and then you say, okay, look, we know you're doing a lot of them. We know what rules you're using, and so therefore we're just not going to feel the need to audit you on every particular case. And so that's where I've seen it. That's where I've seen it the most.
Yeah, I would say the majority of our prior auths that we manage as payers is highly diverse. Those lists are long. So it's just, okay. The last two, just so I know other people have questions, is the standardization of reporting. I totally agree. Once again, it's like what quality measures are going to harmonize to. I love the concept of passive, just partly because of my last decade at IBM and trying to figure out ways to read EMRs and use natural language processing. It really is hard. It's not as easy as saying we just need access to the EMR data. The accuracy levels of NLP, even with medical NLP, we're talking rates of 70, 80%. You can't get that level of accuracy and expect that to work in healthcare. It's kind of like if 1 in 5 times you don't know if you got the right information, you have to check the whole thing. So to me, that's a simplicity on exchange and interoperability that needs to be addressed in your number 4. But thank you for sharing. Thank you.
And thank you, Q. Thank you very much. I want to go to, I'm just watching the chat, and I want to pick on Jeff Levenshurst. Jeff, you made a comment about total savings, like how big a deal is this? And then you weighed in on prior auth. So address briefly one or both of those, please, Jeff.
So to David, obviously great presentation. It looked like the total number of dollars that you thought could be saved compared to the total healthcare budget was much smaller than I would have thought. I actually thought that prior auths probably cost much more, even on just the health plan side. At least my experience from years ago at Tufts Health Plan, I think for simple PAs and pharmacy, it was costing us $45 or $50 a PA. But so maybe there's more dollars there, but a theoretical question, let's say we get to nirvana land, we can get rid of all these, we agree they're value destroying, they burn physicians out, they keep people from getting the care they need. We get rid of all of these were built into the price, right? I mean, they were built into the price for the health plans in terms of the ASO fee. They were built into the price for the providers in terms of the fee that they're, in terms of their fee schedule. So if we got rid of these, but in fact, the health plans continue to charge the same administrative fees they do, and the providers continue to charge the rates, get the allowables that they do now, we would end up with a more profitable healthcare system, but we would not end up with any healthcare cost savings. What could we do to be sure that we're going to get what we really want out of this change?
So I'm glad you brought that up. So here's what the nerd in me says, the nerd being the part of me that thinks thoughts that are completely impractical. Is, so I'm on the Health Policy Commission in Massachusetts. So, you could say, the governor or the legislature could direct us to do this and then say, but here's what we want. We want, David and Health Policy Commission, we want you to say that we are going to save 5% of spending over the next 3 years in administrative expense. So therefore you should say whatever spending would have been, we now want it to be 5% lower over 3 years. And then, of course, the providers and the payers are going to get killed unless they go ahead and make those investments that justify those, that lead to those savings. So kind of bake in the premium and cost savings to all the payers, including individuals out of pocket and governments and insurers, and then through the premiums to the businesses and the individuals paying them. And that then gives you a lot of guarantees that people will really want to find those savings, because otherwise they're going to be doing very poorly. That's the equivalent of sort of creating a burning fire and, on the platform and saying, now now would be a good time to jump. The other way to do it is you can do these and then ex post you can say, okay, and if I don't see these savings, I'm going to get mad at you. And that's a safer way, but I think you're right. One way or the other, you definitely have to be sure that it's not just captured and kept internally or used to invest in something that is of no benefit to consumers or very low benefit to consumers.
Great point. Couple of things coming up here, David. I'm going to give a heads up now, but he shouldn't speak yet. Mike Chernow. Mike, how does this look vis-a-vis $3.8 trillion and where that's headed? If Mike Chernow could kind of give us a national macroeconomic perspective on this, we'd appreciate that. But before that, Mike, Muna Banji, Muna, would you want to make your case about AI? You made a couple of very interesting comments on that. Could you please weigh in accordingly?
Sure. So I just have been reflecting on conversations we've had at these meetings where we've said, what can we do to make it easier to do more of the good stuff and do less of the bad stuff and be rewarded to doing more of the good stuff and less of the bad stuff. And so as David was going through his presentation, it struck me that in so many industries and domains, artificial intelligence is enabling a much more efficient way to bring in the nuancing that is important in this prior authorization discussions that we have had. And we saw a post from Jeff saying, how can we make sure that if we get rid of prior authorizations, we don't end up doing more of the bad stuff? One way to solve that is by having artificial intelligence, the capability applied to the claims data and to the care data for a patient. So for one of the patients, it might be that this intervention makes all the sense in the world. For another, it might be does not make any sense in the world. And that kind of nuance can be enabled by AI and remove this friction that everyone is talking about. So the question is that an opportunity for us in the healthcare system that we can do more to lean into? Because the technology is available to do this.
I'm super glad you raised it. When the issue of gold carding came up, the most common case I hear it is centers of excellence. But the second case that I've heard it about is, I heard about it in one case of radiology where, the insurer and the provider were always fighting over radiology. And so the provider said, I'll tell you what, how about we install software on our computers that doesn't let us do an image unless it passes the American Radiological Association guidelines. So we'll just build those guidelines into our computer. And then you just accept that no image will be done unless it passes those guidelines. So therefore you don't need to question every image. And that worked out well. I'm told it worked out well. I'm not sure whether that's still happening or not much, but I'm told that worked out well. But you could imagine with all the various guidelines out there, coming to some agreement and saying, yeah, for these things where we're doing a lot of this, and where it's routine and no individual one of it costs that much. Yeah, if the guideline says to do it, then go ahead and do it. I think the case where you really want the manual one, where it's worth spending a lot of money is where it's a super expensive thing and it's hundreds of thousands of dollars, and you need to make sure every single one of those is absolutely appropriate and justified, and you're doing it the right way, and so on. And it's fine to spend money on that. Whereas the routine ones, yes, just use AI to say, yeah, that passes the criteria, move the line along.
Thank you. I love Jeff Levenshirtz's point about AI being black box by definition. Gosh, I'm just so reminded by, David, all the stories we hear about algorithms going awry and the biases there. And Jeff brings up this point, gosh, if they're not transparent, we're not going to have maybe a lot of confidence in those. Do you have a comeback to that, David? What do you think?
Yeah, I think some of the AI really ought to be things like the guidelines from professional societies, so that it has to be absolutely clear what's in them. You can't go to someone and say, I'm going to penalize you for something that you can't understand. That makes absolutely no sense. But I think you can do things like that. And, the manual equivalent is, the head of surgery going to the surgeon saying, look, you're doing X, and we've all agreed that X is not appropriate. So therefore, would you like to, we're not going to let you do X unless you can prove to us that we're wrong in our assessment of it.
Yeah, good point. In a second, I'm going to go to Chernu, but I want to give heads up. Up next are Chernu and Fendrick. We'd like to hear from some of our physicians here, our providers. I'm thinking maybe Tilak, you might be good in this. I hope you're on board. We want to hear some doc views on the PA and related aspects, if you don't mind, Tilak, and any other any clinicians who may want to weigh in. But let's go now to Mike Chernu. Mike, give us a big picture on this and how this fares.
So I wish I had a good answer for you, Cliff. If I did, I would, wait, and then I would text David. But since David's here, I will say that I think the administrative costs are really important. I'd be interested in David's thoughts on two things. One of them is the scale of the administrative cost portion of it relative to the scale of doing the low value care stuff that we just are doing delivering too much actual care we shouldn't get. So that's sort of one question. The other question is the problem I see in part, and I'd actually like to hear from everybody on this. A lot of times the lack of standardization, the disagreement on benefit designs, the nuances we put in, the different quality measures, that seems like it's wasteful. I wrote in my answer to you that it's wasteful, but sometimes I think groups see that as their secret sauce. So as soon as you standardize something, it's not going to be perfect. It's going to be some level of an average set of measures. And someone's going to say, you know what? I can do better than that. VBID fits into that perfectly, by the way. People wanted to standardize benefit design, so they raised cost sharing for everything. And we said, well, that's fine, but you could do a lot better if you reduced cost sharing for diabetes. So you could standardize the nuance, but there's always someone that has a somewhat better way, slightly different version, and want to break the standardization per se, unless you have a strong enforcement mechanism. And I think that's probably stronger in healthcare than it might be in banking, because the nature of the secret sauce is a little bit different in healthcare. So if David has thoughts on that, I'd love to hear his reactions.
What do you have, David?
Yeah, so when I was talking, I stumbled through one thing, which is when I was sort of noting that Minnesota requires all the payers to use the same quality metrics. And I said sort of very, very quickly, that could be good or bad. And the thing that was going through my mind at that point was exactly where Mike was, which is to the extent that a payer also influences the quality metrics by, for example, calling up the patients and making it easy to get information about where to receive your tests and when to get your pills and take them and so on, then that really is something where the quality metric for a provider may differ from payer to payer because of what that payer is adding on. And so you wouldn't want to say, hey, you can't use that different metric, or you can't have a payer specific version of it, because it may be that the quality metrics for one payer really truly are better than the quality metric for another payer because of what that payer is doing. And so I think you do need to leave room for that, or otherwise you will get rid of all incentive to say, how do I make sure that this particular payer is doing everything it can to help out the patient?
Yeah.
Thank you, David.
I just want to add something. or you'll miss out important dimensions of quality because your standardization will move you to the least common denominator of what everybody can do. And so they won't be patient-centric enough because not everybody can do the right survey, or they won't be able to deal with the quality of diagnosis because you don't have all the right EMR things and stuff. And someone will, again, I don't have a good thought to this because I basically agree with David's broad point. It's just this trade-off between standardization and telling people what they can't do because it breaks the standardization, I feel would be frustrating to a lot of folks.
Point well taken, Mike. To be followed on. Over to Fendrick and Dr. Verma on deck. Mark.
Yeah, I want to go back to the point about prior authorization. And so on my screen, we have 3 brilliant PhDs, Goodman, Cutler, and Chernu, and 3 clinicians. We got Verma and Levin Schertz and myself. I have argued, so David, you haven't been here before. Dr. Verma, you've never been here before, and Jeff. So I have argued at previous meetings of this task force that prior authorizations in this country are aimed at expensive services, not low value care services. So Jeff, if we put prior authorization on the things that we've identified as low value care, there wouldn't be a problem. The fact that prior authorization is not clinically nuanced, and I love, Muna, you made this point so clearly, that if we applied this idea of good stuff and bad stuff and understanding that it's not just a service, it's a service on who gets it, when, by whom, and where. And that's hard. But I think, I would also think that Dr. Rhee would agree with us. If we were talking about putting a prior auth for colorectal cancer screening under 45 and over age 85, clinicians wouldn't mind doing that. And Dr. Keats, our old friend, he's put prior auths in place to make sure that people aren't ordering vitamin D tests around the country. And several other insurers have followed suit. So there are some services like vitamin D testing that are used in a low value care situation a great deal of the time. The problem is that most of the prior auths are services that have a relatively low value index, meaning they're done fairly commonly, and they're trying just to prevent people from doing expensive stuff that is often clinically indicated, which is something we should get out of the way of.
Mark, thank you very much. David, do you have a take on how we would redirect prior auth to those low value care services as opposed to just the ones with big price tags?
I keep coming back to me as the economist, which is if there's a price for it, then it seems like the payers will figure out which ones are really worth it. Right? Like, let's say you have to pay either the $12 that CAQH estimates or the $40 that $40 or $50 that Jeff said they were finding even a while ago. If you had to pay that every time, then there would be a lot of thinking about, okay, which of these are we getting our money's worth by getting rid of this, preventing the services we don't need and so on. So I don't have in my mind, I don't have a sense about like which ones I think I would get rid of. I'd almost rather put in place a process that says you got to pay for it and then you get rid of you as a payer can decide which ones you don't want to do. And oh, by the way, I'm going to make this be as electronic as I can so that even when we do it, it's going to be at lowest cost.
And David, that's why we argue for non-coverage, right? And have physicians be liable. So the few places where we've made physicians liable for low value services, you can imagine as an economist, the utilization of those services plummeted. And prior auths, I agree, and I'm looking at Dr. Rhee's comments. Yeah, prior auths the more nuanced we get with payment and benefit design, the less we'll need prior authorization. But that might be a dream for me, Cliff.
Let's hope so. Dr. Verma, we'd very much be interested in your weighing in from a longtime clinician's perspective, please.
Thank you. One of the slides that resonated with me, and although I work and trained in Boston, my practice and my home is in Rhode Island. And so one of the slides that resonated with me was the one that was entitled Traits Associated with More Low Value Care, Large Proportion of Non-White Patients, Serving Areas with More Healthcare Spending, No Major Teaching Hospitals. So, I think we are talking about a very homogeneous approach to this problem where it's, where it might require a different approach in different areas. So in a previous role, I wrote the medical necessity guidelines for sleep studies. When could you have them at home? No prior auth needed. And when you could have it done attended in a lab where the cost was, many factors higher. And there was no way to do this without prior auth. And those policies we wrote in a very big national pair in around 2010. And I do the same thing for my health plan here now at point 32. And we still continue to see the need to tell the providers that you can do this without any authorization or necessity going through anything. You can just do it automatically at home. And maybe COVID made a slight shift, but we are back to normal. Sleep labs are open, and everybody wants the more expensive test. With regard to gold carding, I think we outsource our imaging to an outside vendor, and they do have some sort of a process for it. But I don't know how universal it is, how many providers it's applicable to. So, I think in summary, what I'm trying to say is that some of these things would work very nicely in the Boston area with academic hospitals, with full-time employed physicians. In Rhode Island, where we are made up mostly of onesies and twosies and only one teaching hospital system, the approach would have to be substantially different.
Thank you very much, Tilak. David, do you have a take or response to Tilak on kind of his perspectives on willingness to do this, where and when?
Yeah, so I've wondered how much of this is really a big, provider system thing. I think a lot of smaller providers sort of contract out the claims processing and stuff like that, and the big ones sort of do it in-house, and so they probably know a little bit more about exactly what the headaches are, whereas the smaller ones just sort of pay the bill and get around with it. I guess I don't know. My sense is that the sort of all the hassles, particularly around prior authorization and stuff like that, are probably a more existential issue for smaller providers than bigger providers. Because if you can't manage it, you say, fine, I'm just going to go and be bought out by, big healthcare provider, Inc. And they'll be able to manage it for me. And so I on the one hand, IT by itself brings folks together into big businesses, but on the other hand, the lack of IT probably forces you into big businesses as well. And so I don't know whether we would be able to keep how this would work exactly with the smaller provider practices. I am nervous about designing something that would be too difficult for them, but I also suspect that they're not doing well now anyways. Wait, Cliff, you're on.
Yeah, I'm just saying, thank you for that, David. I just want to commend to folks the nice exchange, interesting exchange between Muna, Q, and Chris Jude about AI and versus humans. I think Q made the point that it's not just AI, it's AI plus humans and how efficiently that works and so forth. So we won't go into that more now, but I do commend it to folks. So David, just a couple of minutes left. You were kind enough to kind of lay this out, frame it up so nicely with your 4 models and these other kind of issues. And again, the within versus the between. David, having heard this feedback just now in the last nearly half an hour, would you want to recast or recalibrate or reprioritize what you think would be our next steps, particularly given our shared interests in reducing low value care in this country? What are your kind of wrap-up thoughts, David?
I started it off by saying that I do not consider myself an expert on administrative stuff. And indeed, most days I can figure out how to turn on the computer, but not every day. So I'm really I feel like there's some things I really truly feel like I'm an expert on, and people should listen to me, and because I've studied, and this is not one of those things. So I think that I am totally fine being told I'm wrong here. I'm totally fine being told the solution isn't right. What I'm hoping to do with a lot of these is to spur folks to say, what do we do next? Like can we all sit down and figure out what do we do next? And so that to me is the thing. There will be, as I mentioned, there will be a report coming out from that I've helped some folks at McKinsey do. Hopefully that'll lead to more national discussions. Hopefully a group like this, people can say, is there something we can actually do? Even if this doesn't make sense here, does this spark any ideas about what we can actually do? And so that's really where I do not feel like I have the answers. I feel like I certainly know some of the questions and I have like provocative ideas on some of it, but that's as far as I really want to go.
Okay. David, you might remember this. I think it was 30 years ago that, was it Himmelstein wrote a paper that kind of presages our discussion today about how much huge administrative waste there was in our system. And you seem to echo that. I'm not sure if you had that in mind, but don't you recall that arc of thinking?
Yes, in fact, and where that arc of thinking led to was, single payer is clearly the only answer. And it is true that single payer countries have lower administrative expenses, but it's also true that every other multi-payer country has lower administrative expenses than the US. So even relative to, and multi-payer countries have higher administrative expenses than single payer countries do, it's just a thing, but they're all lower than the US is. So the US is sort of uniquely inefficient. And I think it's partly because, to just take one specific example, the price of a surgery is much higher in the US than elsewhere. So therefore the insurers in the US have got to figure out you've got to say, okay, I need to make sure every single surgery is justified, or every image, because every image is more expensive. So because things are more expensive, you have to audit more, and then that builds in even more into the cost and so on. And so that partly what some of these other countries have figured out is that the less expensive the thing is, the less waste there is from not auditing it. And so therefore you don't have to worry about that much.
Great point, well taken. Well, David Cutler, good gosh, you are worth the wait. You keep claiming that you're not an expert in this, but you certainly stimulated a lot of thinking on our part. This could have been a grad course in advanced health econometrics. We got a big kick out of it. You prompted a lot of discussion. Thank you very, very much, David Cutler.
Thank you very much.
We'll be in touch. Thank you, sir. And with that, it is a pleasure to hand it over next to Meredith Rosenthal. Meredith, you know by now that everybody's been thinking about disparities from every which angle possible. We are waiting from your answers on high. We'd love to hear what you've got to say now about this, Meredith. And if you happen to have any reflections on what you heard from our folks as well, we'd welcome that. But I give you Dr. Meredith Rosenthal, the C. Boyd and Gray Professor of Health Economics and Policy out of a well-known institution in Boston. Over to you, Meredith.
Thanks, Cliff, and thank you, everyone. Good to see you. Good to see you, Jeff, and all the rest of you. I see some other friends in the room, so that's terrific. Wonderful. Well, let's see. Maybe I will just say that I am really delighted to talk to you about this issue, and I know that I don't need to motivate it too much with this group, but while health equity has always been a top health policy issue, it has clearly risen to new heights in terms of the national discourse. And one of the things that I've been thinking about lately is how we can make the way we collect data and use it for research and disseminate that research, how we can make that support better policy. I don't have a lot of thoughts on AI, but it does remind me a little bit sort of where you end up in that conversation. These are challenging problems for which we don't have a lot of clear answers. I'm going to try to resist the urge to sound like a researcher and conclude that we need more research, but I think you'll see one of my conclusions is that we need more data, and I'm hoping that you all can help with that. So here we go. Can you see my screen?
Clear as day.
Excellent. Wonderful. I'm trying to be cheerful, blue sky today, as the weather dictates here in Boston. So let's see, which way does it want me to use my cursor? For some reason, it's not wanting to let me move my slides. Okay, sorry. Not sure what's going on.
Is there something?
Here we go. All set. Yeah. It just didn't like my arrows, but now I'm good. So again, Mark was kind enough to send me an email to say that you've already started this conversation, and I know all of you live in the world and are trying to make that a better place. So it comes as no news to you that health disparities in the U.S. Are widely understood and really widely documented in terms of their magnitude and the fact that they are pervasive. And I say in the US because that's my research context, and I think that's what we're talking about. But health disparities along lines of gender, race, ethnicity, religion, they exist everywhere. They are not just an American problem. And then I just want to put what we're talking about in a little bit of context, again, not to educate you, because I know that you all understand this, but disparities in health outcomes are not just about healthcare, but they come from structural issues, from really deep divisions in where people live, and that has historic roots, where they work, and the kinds of opportunities they can access in their lives that affect social mobility and well-being. And conditional on all of those things, we still have strong evidence that there are racial and ethnic disparities in the care people get actually in the healthcare system. So I just wanted to share just a little image, again, to put some context, because my work is very much in the healthcare system. I look at the role of health insurance and other kinds of payment mechanisms and financing issues that affect healthcare delivery and how people access care. And so my work sits in this diagram at the bottom of this cliff. So this cliff comes from Kamara Jones. Many of you have probably seen it. She is a social epidemiologist who is really one of the most brilliant communicators, I think, in the health disparities space. And she has come up with all of these images and stories about how health disparities arrive. And in this story, she's talking about people who are at risk of injury due to falling off a cliff. And she wants us to think about issues that are sort of fundamental, the structural issues I talked about before: discrimination, criminal justice issues, food security, as being all about keeping people away from the cliff. So that's sort of the most preventive that you can get. And then you can have a fence in front of the cliff, and that is her image for public health interventions. And then we could have a net to catch people if they fall. And that's the health system we put in place to try to increase access and deliver care to underserved populations. And then at the very bottom of the cliff, once they have fallen, the ambulance can come along. And if it's a good ambulance, people have a better chance of survival. And that's really what we're talking about today, is the quality of care, given that people actually access the health system. So as important as this is, we should remember that in the larger context, that's a very small piece of the story. So what do we know? We know that that data for decades have shown that Black and Hispanic people are less likely to get high quality care. And let me just step back for a moment and note that the terms that I'm using for racial and ethnic groups reflect the way data are captured in our claims data systems, and in particular in Medicare and Medicaid. There's a very important conversation we could have about how people self-identify and the richness of that self-identification and its importance for disparities. Because I'm talking about research studies that rely on data that use these terms and that typically do not have enough detail to be able to look at subgroups of race and ethnicity. That's why I'm focusing on these terms today. There are some studies that have more granularity in them, but most of them rely on these subgroups, white, Black, and Hispanic, as the largest subgroups in the data. So happy to talk more about that if you'd like. So we know that these racial and ethnic minority groups in the US are less likely to get high quality care. And when I say high quality care, I'm mostly talking about process measures of care, the care that either through randomized controlled trials or consensus panels, our healthcare system has identified as evidence-based and recommended services. This is also true that when we look at health outcomes, particularly in the inpatient setting where there is quite a lot of research, including mortality and complications after surgery and readmissions, that these disparities persist. So it's both the care that people get and the outcomes that they have. So our research question in the study that sort of motivated the conversation that we're having today was born out of that body of research and our ongoing interest in low value care. And so we wondered in particular whether Black and Hispanic patients have different levels of low value care than white patients. And our data come from Medicare. So we're looking at that context where everyone essentially has the same insurance policy, although there can be different supplemental packages. And part of our curiosity about this was that we wondered if Black and Hispanic patients got less of everything, including less of that care that might not be indicated. And so that there might be somehow a benefit to the lack of access, unintentional as it might have been. We also wanted to understand the relationship between overall healthcare utilization and low value care, in part because that was our theory of, in terms of the mechanism, that access might actually have an important effect on this. And so I see there's some excellent comments and references in the chat relating to this question about how we characterize certain Asian groups and Native Americans and others. Very, very important topic, and hopefully one we can get back to towards the discussion. So I won't bore you too much with the methods of the study, but we took 5 years of Medicare data from 2006 to 2011. This study was published about 5 years ago. And we looked at a set of choosing wisely measures that cover a range of different kinds of services, including imaging, screening tests, as well as some treatments and other kinds of interventions like feeding tubes in patients with advanced dementia. And we used a statistical model where we controlled for a number of both clinical and other factors, including geography, for these patients, and compared the odds of receiving these low value services between Black and white patients and Hispanic and white patients. And this chart basically summarizes our findings. The dots essentially look at, oops, sorry about that. I was trying to move the picture. So the dots essentially look at those odds ratios, and that dotted line that's running up and down the chart is an odds ratio of 1, which would mean the two groups were being treated roughly the same. And so you can see there's quite a bit of variation across measures, and many measures in which Blacks have higher rates of these low value services than whites, and Hispanics have higher rates of these services than whites. And they're a little bit different, but the most extreme is that feeding tubes in patients with advanced dementia. And some of the other measures have relatively small effects or odds ratios that are below 1, meaning that in fact, Black or Hispanic patients are less likely to get these kinds of low value services. So choosing wisely measures typically tell us not only about really unnecessary care, but often they describe care where, in fact, ignoring the financial cost of the treatment, the risks exceed the health benefits. While Choosing Wisely, of course, is open to identifying measures that are essentially not cost effective. In fact, many of the measures are about what one of my colleagues has called no value care. And so what we're looking at in some cases is real evidence of potential harm. And alongside that, of course, increases in both out-of-pocket and total costs associated with this use that has a number of consequences, both to the individual and collectively. So almost surely we're seeing evidence that low-value care is exacerbating these disparities in health and well-being. And collectively, they contribute to inefficiency in the health system overall. So what do we really need to know? That study was really intended to get at the question of existence. Do we see disparities in low-value care? And we found evidence of a number of places where we do see disparities in low-value care. And so what we need to know now are what to do about it. And in particular, we don't have very good information on the mechanisms that cause, in this case, Black and Hispanic patients in Medicare to receive more low-value care. We have controlled for certain factors, so we have some sense of what's not important that we can observe and what is important that we can observe. But for example, we don't know how much of these effects are caused by discrimination versus by Black and Hispanic patients seeking care with different kinds of providers. And there's a pretty substantial existing literature on healthcare quality in the hospital setting using those process and outcome measures that I described earlier that shows that a substantial portion of the difference in quality between Black and white populations and Hispanic and white populations is in fact caused by where those groups seek care and not just within system differences. On the other hand, we also have fairly dramatic recent evidence that within system differences in the quality of care, particularly around opioid prescribing, can be quite substantial. And that suggests a very different mechanism than the fact that people might go to lower quality hospitals or seek care with lower quality physicians. So one big gap in this literature is that almost all of these studies are done in Medicare because of the relatively good quality data with race and ethnicity coded in it, with all the limitations that I mentioned and that we can discuss further. But private insurance data almost never have race, ethnicity. There are some algorithms that people use to attribute race and ethnicity to patients, but clearly those are not, they're not at the gold standard of self-reported race and ethnicity. So we really need to know more about what is happening in private insurance, where cost sharing differentials might be quite important across these groups as well. And then of course, I'm sure this group has talked a lot about what are the best tools overall for reducing low value care and to understand which of those tools might simultaneously reduce the disparity. That has been a challenge in quality improvement overall for many years, as we may find things that work to improve overall quality, but they leave the disparity intact. So how can we do better for particularly the most disadvantaged groups in terms of their current access to high quality care? And then what could employers do in this context? Well, I do think the absence of data in the private insurance world makes it really hard to think about evidence-based policymaking. And we have some local payers who've begun to systematically collect self-reported race and ethnicity from their enrollees so that they can use that information to understand disparities within their own insured populations and also design policies to address these issues. And I think employers have an important role in advocating for that kind of data collection. And then, I think then we can look at the other kinds of mechanisms that people have tested and suggested with mixed success in terms of reducing the use of low value care, motivating through incentives or educating employees about the existence of low value care. And I'm sure you all know that Consumer Reports designed some educational materials for that purpose. But then there are also steering mechanisms to the extent that provider selection is an important driver here. We can use a variety of benefit designs and other tools to help patients find providers that not only deliver evidence-based care, but also do not deliver low-value care. So I look forward to your comments, your ideas, and I'd like to go back to the discussion. I'll stop sharing.
Thank you very much, Meredith. And you hit on several important points. I have to say that one thing that struck me and got me a little upset was the feeding tube thing. I picture that, and I'm not a clinician, I may be missing the point. I picture that it might be easier just to stick a feeding tube into somebody and kind of set them aside as opposed to spend more time with them to try to help them gain nutrition. And it was just such an outlier. It was a little upsetting, actually. Are there other instances like this that are revealing in similar ways?
Well, I think you ask a question that is sort of about the nature of the Choosing Wisely lists overall, and I'm not a clinician either. So I agree. In part, we largely chose measures that would pick up a large population so that we would have the ability to statistically compare the rates of use. But it is true that at least in the early years of Choosing Wisely, there seemed to be an emphasis on measures that were sort of incontrovertible. And I think those measures where one can show harm are much easier to convince clinicians that they should really try to eliminate those. And so I think that, we do see a set of measures in Choosing Wisely that look like that, as opposed to measures where services have benefit, but they just have very low cost effectiveness.
Got it. There's a conversation involving, good gosh, Q, Denise, Nancy, and others on the so-called REL data.
Right. So I see people talking about the data that employers have by virtue of their role as employers, as opposed to by virtue of their role as insurers. I'd be interested. It's my sense that those data cannot easily be linked with health insurance data, if at all. It seems that it's crossing boundaries.
I'm sorry, that's not correct.
It's not correct. Tell me more.
What do you have, Q? What do you have, Q?
Well, look, employers have the data, they could share it. And we have it for a lot of our employer clients. So
they shared, tell me more about what they share with you.
Race ethnicity data that they obviously collect. I mean, they're part of their diversity efforts. It's an HR data file in order to get linked to the payer. We have their date of birth, obviously, as a payer. We have their gender. We have where they live. We got to bill them. So it's just another file.
Meredith?
Yeah, so I'm curious the extent to which you can use that for analyzing their healthcare use. I understand that employers have those data. So tell me more. Are those data you're able to link them to people's healthcare use so that you could examine disparities, for example?
Of course, yes. I call them equity dashboards. You could definitely do that. We did that at IBM when we acquired Truven. Equity dashboards were standard, but you're right. There is a lower percentage of employers who feel comfortable sharing the data. And I think a lot of it is fascinating, those dialogues as to why they don't feel comfortable, when clearly a payer has all this other sensitive information, the date of birth, the geography, even what conditions and drugs you're taking, whether you have HIV or depression, all that data is secured by the payer. Yet we are reflexively uncomfortable, some employers, in sharing race ethnicity data. I think that's one of the inequities about equity. It's kind of ridiculous that we talked about crossing the quality chasm at the turn of the century, safe, timely, effective, efficient. You're trying to align equity and efficiency here with low value and equity, patient-centered, but ultimately equity was not as valued when it comes to racial and ethnic minorities. Now, I think there's a different time now with the pandemic and some people getting more woke about issues like George Floyd and Breonna Taylor. So, but this is a moment to say, just share the disparity, the race ethnicity data. And they often have more granularity. They have, I kind of want to highlight it as an Asian American who's looked at disparities. Like I feel it's important to recognize there are many other groups that were represented in your study, which I know is just one,
Absolutely.
Minority health is becoming majority health. And so that country of origin data, the language data is all there. So if we're going to expect to address equity, we have to expect that data is part of what is looked at.
Thanks, Q. Meredith, any comeback on that? By the way, Denise and Mike on deck. Denise and Mike on deck. Go, Meredith.
Great. Yeah, thanks, Q. That was both an education about the fact that employers are already linking these data. And I agree with you completely on the broader race ethnicity, which is why I acknowledged it up front, is we're working within the constraints of the Medicare data at the moment, but it's clearly not enough. And I'm very curious for others if they have a take on what would it take to get employers to link these data more systematically. And I also wonder, I don't know as much about the HR data systems and in what context people provide their race ethnicity data. And sort of how those questions are asked and how that might compare to data that health insurers could collect and are collecting in some cases. So,
okay,
Cliff,
so
I'll leave it to you to tee someone else up.
Well, it's going to go Denise, Mike, and Nancy in that order, if you don't mind. Denise, thanks for your patience.
Sure, no problem. So just quickly, depending on the size of the employer, they do have concerns with linking that data because the reports out could end up identifying some specific employees within their population with certain disease states because of having a low representation of either that race or ethnicity. So that is one concern. Employers have to jump through incredible hoops these days to get their data out. What they have to go through with their legal team. We've got some employers who have joined coalitions just to be able to pool their data, and it's taking them over 3 years to get their data released. So just to give that little bit of background. And I had another point, but I forgot it, so I'll
sorry. Yeah, and that's, I think your point also, reminds me that if we're looking at small employers, of course, what we need to get a bigger picture of what's going on. Of course, employers want to know what's happening with their employees, but it would be hard to characterize, for example, disparities in a group of 100, just because the numbers are not big enough. We need to aggregate data. So some kind of data pooling or using data that cuts across multiple insured groups would be really important.
Excellent. Thank you for that point, Denise, and that benchmark of the 3 years. Over to Madalena. Mike?
So what I'd say is my comment is probably on the other end of the spectrum. Many of the employers I deal with plans, I'm going to use that word carefully, they're not the employer and do not have the data. Many of these, especially the large state health plans, state groups, they're multiple employer plans and don't have access to the HR data. I mean, love to have it. It would be very useful to have on these large plans. They just don't have, they can't have it because they are not the employer. The plan is the plan sponsor, but not the employer. So therefore, it's just verboten. Love to have it, but it's almost impossible to overcome.
Point well taken, Mike. Thank you for that. Let's go out to Washington again with Nancy. Nancy?
So thank you, Cliff. And I want to echo what Denise has said. We're a purchaser-led coalition. We work with all the stakeholders very closely. So all of these folks are our members, and I think she's spot on. And I would just say it's an issue of trust and developing trust to the level that you're exchanging that sensitive data and the choice that employers make with whom they want to share it with, which may or may not be a health plan leader, may or may not be a hospital setting or any of the other stakeholders in healthcare. I just think is really a key driver. I do think this area is evolving. We are having a lot more conversation within my organization about DEI issues and getting access to data, but I think it's an issue of trust. Thank you, Nancy.
Thank you, Nancy. Let's go out to Bethesda, Maryland with Tracy at USIS. Tracy.
Hi, I'm coming off mute to talk, and I'm going to put my hand down even before I start talking, so I'm not embarrassed later.
Good hygiene.
Really, there we go. So what I would ask is, so who's published on this? Like, where's the best measures? I have this. I've got 9.6 million Americans, adults, children, only 18% are in the military. We have publication after publication that demonstrates that we ameliorate racial disparities on a variety of different topics. I'll be talking about this at APHA on the 25th. But I'd love to cut and publish one more big project where I combine my two true loves, which are low value care and disparities. Who's got a paper out there that I can duplicate? Because we've done a set of pediatric measures with CHUA. And then we did we didn't do any McMaster ones for the adults. We went with some Jody Siegel measures. We did 19 out of her 20 adult measures that she had cut in Medicaid. If someone can send me a cut of measures, I'll have my team get busy. I would love for us to show you all, what we're doing, and especially not just inside our system where we pay and treat our own folks, but we generally believe, because the evidence shows us that our African-American, Native Pacific Islanders and white patients get similar treatment for a variety of different areas that the rest of America doesn't enjoy. And I would love to be able to look at that for low value care. So thanks.
Yeah, so Tracy, I'll just answer quickly. This isn't that complicated. And I put a Techquity article that we published in the Journal of Healthcare for the Point of Serve with someone at Harvard and at IBM. It is about data trust. And it is about equity dashboards. All you got to do, whether it's mammograms, vaccines, whatever your condition is or low value care, you just need a toggle between the race data and the white versus black, just like it was shown in the health affairs.
Right. No, but we do it all the time, right?
Right. Yeah, most people, a lot of people,
our cancer screenings, but I would prefer to adopt someone else's measures that they've already used and demonstrated that they're good measures for capturing equity in a health system or disequity and disparities and differences by groups, and adopt that rather than go back to, I guess, the 39 measures that we did the last time. Because my team would go out of here screening, but if there's an article or something that you guys have, we'll use it. It's only the 15th of October. I've got unlimited access to this data until the 30th of January. I got time.
Well, Tracy, you're leaving the door open for various takers then. She's laid down the gauntlet, folks. We can respond. Over to Fendrick.
Tracy, I'm a taker. Talk to Miro. I've been trying to do this for 5 years. And again, I'm just so amazed about how the new first-time folks, and Meredith, you were absolutely amazing and you overachieved your already expected high bar. So Tracy, we have to have a conversation. Elon knows the work we're doing, and we won't have time to talk about just our education on this issue of your two favorite areas of low value care and disparity. So I want to ask Meredith a question, actually, Cliff, is that okay? And I'm going to bring in the Yogi Berra, predictions are dangerous, particularly those about the future.
Go ahead.
So the VBIT Center folks on the call know that we have been holding your health affairs paper up very high, how sad we were to find out that given an environment of 30 years of papers showing reduced access by communities of color, that when they finally break through all the problems of not just having clinicians to go to, insurance, transportation, hours, all these things, that they actually get more care they shouldn't be getting compared to the people who don't have those same struggles. So your data are now 10 years old, and they were in Medicare. And many, many, many people, and we have studies underway, as you probably do too, but so the people on this call know deductibles are what keep me up at night, because deductibles are disparity creating, which we showed a very, very long time ago. But would you guess now that if you replicated the data in 2021 instead of 2011 in commercial plans, that the bad care that was happening a decade ago will overwhelm or be underwhelmed by the problem that we have been focused on, which is deductibles being the blunt instrument to keep people away from everything? Because they work against one another, as you know. Medicare people, for better for worse, have better access, even if they're a community of color. That is not the case in the 150 million commercially insured folks.
Yeah, it's a really good question. I've been thinking a lot about changes in cost sharing over the last decade, and it very clearly is shutting a lot of people out of the healthcare system. So I can imagine that the biggest disparity is access, and that may diminish the disparity in low value care that we're seeing here in the Medicare population 10 years ago. So I guess if I had to guess, I would say if we look today in a commercially insured population, that those disparities would be less. I think if we controlled for deductible and cost sharing, they would be probably the same size.
No, because I'll just say one last thing quick, Cliff, and I don't have to say goodbye at 4 o'clock and say you've done an amazing job as always. You're my hero. But I have said publicly about deductibles for 25 years that the only good thing about them is they reduce low value care, and they probably reduce them in communities that need the reduction the most. And we have your paper pinned up on our walls because, oh my gosh, you might have proven that glimmer of light of the blunt instrument and made that untrue as well. We have some studies in specific. No, we're looking at cognitively impaired populations where it's on people of color with cognitive impairment. And if that doesn't turn out and your data are replicated, I might just go back to seeing patients full time. So,
well, amen to that. Thank you. Gwen Darien is there, and Jeff Levenshirtz is on deck for some pointed comments. Gwen, you're up.
Yeah, thank you. I guess I wanted to go back to some of your early comments, Meredith, where you really set it up with the context. And I think with the context of being of structural racism, of social determinants of health. And I think if sometimes when we get so deep into these discussions of measures and discussions of things that are very far away from the social and the socio-political context, we really lose what this is for. And this is to create equity. This is to create equitable outcomes for patients. This is to reverse many years of embedded racism in the system. So I kind of got lost in all of the conversation after we started talking about that. And after we went past the context and went and because we're looking to reduce disparities to create equity. We're not looking to reduce disparities just for the sake of reducing disparities. There's a greater kind of moral imperative. Yes, going back to Kamara Jones. The other thing I would just add in, and I see Lauren Vela's comment in it, is this comment about how we were trying very much to, because race is a biological construct, to get beyond it and to get beyond talking about race. But what we forgot what we lost when we did that is we stopped talking about racism. So in this current political moment and socio-political moment, we really have the opportunity to talk about racism and how racism propels the system. So it's not just about access, it's access to equitable quality care. It's not just access to care. Because if you just getting access to care is not enough. And then I just wanted to finally say, and I'll post it in there. I am Reggie Tucker Seeley and I are co-chairing a workshop. You love Reggie. Yeah,
I was one of his mentors when he was at Harvard.
The world is so small, but Reggie and I are co-chairing a workshop for the National Academies on promoting health equity for cancer care. So we're going to deal with a lot of these issues in that workshop. So I will post the link in there. And so if whoever has time and willingness to participate, I think we're going to talk a lot about context, racism, intersectionality, all of
Thank
these.
you, Gwen. It's the right time, but it is a highly charged time at the same time.
Yes, it is. It is indeed a highly charged time, but it gives us even more impetus.
All true. Thank you, Gwen. Jeff Levin-Shirks, what do you have for us?
Oh, what happened to Jeff?
Yeah.
Sorry about that. Meredith, great presentation, of course. I just wanted to raise a caution that my experience is that employer data on race, ethnicity, and language is often not nearly as good as what has been described here. And even employers that are, as has been pointed out, many people don't fully trust their employers. They're not sure what that information will be used for. And I don't know that there's time to really ask Meredith this, but I'm sort of curious. I believe that using census tracts and imputation is going to end up ultimately being better, but I'm curious whether you've already gone down that road and you think that's terrible too.
I think it really depends on on where you are. I think, and we don't have great validation studies, but you can imagine that to the extent that racial segregation is really good, as in really bad, that those area level measures will be better. So I think it will vary, and there is a lot of concern about the noisiness of those measures and the other kinds of name-based algorithms. But I haven't really seen the study that sets that apart. So maybe Jeff, you should do that study.
Okay, well, maybe you can get that funded. We're seeing a lot of back and forth as well on the self-reported versus race ethnicity imputation. Can't get into that now, but it is certainly something with which we need to deal. There's a lot of distance between some sort of truth and what we see in the data, as always, of course. Meredith, having heard all this wonderful feedback, we wonder if you could reflect on what you were thinking coming into your presentation, what you just heard, and where you might go next with it. Meredith, some closing comments, if you would.
Well, I think it's always wonderful to talk to a group like this because I can see you're all very action oriented. And there's an inherent tension between what I think Gwen brought us really clearly back to, the fact that this is a systemic issue. And inequities don't just occur at the point of care, and so that means that we have to act like a system, and employers working with other stakeholders, and both in the private and public spheres, that all of that is going to be required in order to address these issues. I don't think it's not worth addressing them at the point of care, but we do need to keep in mind also that it's not enough, and employers have an enormous role in providing good jobs and the possibility of social mobility. I mean, they have lots of other roles that are at the top of the cliff, and I think that's important to keep in mind that. And I'm sure this group is sophisticated enough to be thinking about that if you're worried about health disparities, you should be worried about your local schools and everything else, and not just who's in your network.
But Meredith, I push you a little bit more on that. Can we afford to be optimistic about closing the gap, narrowing the gap in disparities? The pandemic has revealed some really sore spots and even wider gaps, and the political discourse does not seem to be very supportive of it. Just kind of looking long, do you think we'll ever kind of narrow these down?
Cliff, wow. Well, I don't think we can be optimistic in the sense of complacent, but I think we should feel the burn of that fire behind us. And the fact that we're having this conversation in this group, I think says a lot about, the sense of momentum here. It's not at all a foregone conclusion that we will address these issues, but we certainly won't address them by not measuring, not working on them. And that work needs to be multi-sectoral and collaborative.
Well, thank you, Meredith. I think that you've provided some tinder for the burn here, because you've got such a great invigorated response from everyone, as evidenced in the discussion in the chat. So thank you. You've really graced us with your presence here and your insights. This has been wonderful.
It's been my pleasure.
We'll see you again sometime soon, I do hope. So that was a spirited discussion. I think we've got another slide or two as we close here. Let's see what comes up next.
Skip up. Go to the.
We'll go to the next.
Yeah, skip to the second to last two, Jordan, please.
Yeah. Thank you, Jordan. Okay.
Keep going.
Keep going, I think.
Keep going.
Keep going. We've done this.
This is your little preview into our infographic on disparities in low value care.
Yes, do keep in mind that when you visit the website, you'll see some cool new graphics. I've always found those useful to pop into slide presentations and so forth. They're getting really good over there, the VBID Center and elsewhere, putting across those complex issues in a great graphical form. So, as always, great thanks to our sponsors. You see them there. They have been loyal, supportive, and unbiased as far as I can tell in the discourse. So great thanks to everyone there. Insofar as a next meeting, which would be the next slide, I think. Yes, there you see, it'll be a virtual convening as far as we know. It'll be the 11th Low Value Care Task Force on that Wednesday, April 27th in 2022. Same time slot, 10 to 4. Mark it down. You will be hearing announcements and other bits about this meeting from Susan Lynn, as well as other folks at the VBID Center. I will say this, that coming into today's conference, or just kind of conferencing into this, I've had some ideas about what would happen next. I got to say, I'm not sure what we want to cover next. There's so many great topics that have come in on the chat and in discussion. We could take this a bunch of directions. I do know that one direction in which we will take it is progress. We have a real deep and broad set of stakeholders, people that are vitally interested in this, some really smart, quick thinking people. I'm sure that we will continue to push this forward. I also know that if you have ideas for input on what you would like to perhaps build into the agenda for the April 27th meeting, we would be glad to hear that. Email, chat, whoever you want to put it in. We'll try to put together a really strong program that merits all the great attention and thoughtfulness that you've brought to this. So with that, great big thanks to all of our members, our new and continuing members, our out-of-site speakers who were great, and all the wonderful input that you've had in so many ways today. Everyone here learned a lot. It's always great to meet with this group. I always look forward to it. Take care, everybody. It's been great working with you today. Do stay in touch. Bye-bye.